Good afternoon. Thank you for the witnesses being here today to discuss a crucial issue before us, investing in a healthier America, chronic disease prevention and treatment. Chronic diseases such as cancer, heart disease, and Alzheimer's cases are skyrocketing, according to the American Cancer Society. In the coming year, we're expected to hit a bleak milestone. The first time of new cases of cancer in the U.S. are expected to be across the 2 million mark. This daunting number tells me that we need to invest in technologies that will be able to catch these chronic diseases early and often. We have another growing challenge. Over 45% of the nation's adults are obese. It's hard to imagine that number, but that's what the number said. And the sadder part of that, the over 20% of the nation's children are obese, 20% of the nation's children. For the sake of ourselves, our children, and our communities, we must do better. In fact, we are about to eclipse 19% of the GDP going towards health care expenditures, while Medicare just surpassed, first time, $1 trillion in history. In Israel, for example, they live five years longer than the average American and spend less than 8% of their GDP on health care. We need to learn from our neighbors and our friends about how to do a better job of it. Not that we don't do a lot of good things in terms of the health care space, but there's a lot more that can be done. Many families don't have the time or the resources to analyze and read the food labeling to understand what they are really putting in their bodies. That's why it's critical our nation medical providers have to have the tools necessary to educate their parents on the importance of nutrition for them and most importantly for their children. To bring awareness to this issue, Congresswoman Glenn Moore and I recently launched the Congressional Prevention, Health and Wellness Caucus. Our bipartisan group focuses on prevention, food is medicine, exercise, and doing what we can to get our military more ready. Effectively, the readiness for the military, I'd like to thank Congresswoman Moore for joining me in that critical initiative, and I urge my fellow members to take a look at the subcommittee as well. The obesity epidemic has also, as we talked about from a national security standpoint, according to the American Security Project's obesity rates among active duty service members, I went in when I was 18, so I know got some sense of it, but an active duty service member is double in the past decade as we face in terms of obesity. This growing threat from our adversaries across the globe. We cannot afford to have an unfit and unhealthy military to address major international dangers. Stocking in those that try to get in the military between 17 and 24, 1/3 of the adults are overweight and unable to serve in terms of the military. We are about to hear from a great group of folks, and I've followed these, especially the senator, for the last 30, 40 years. It's hard to believe, but I'm very excited about a great group of folks that we've got today that are on the front line of these chronic conditions, and ensuring prevention is the main priority in the medical field. As Senator Frist said in a recent article in Forbes, we all need to prioritize and going back to the very basics, and the food we put in our body is the key. I'm pleased to recognize the gentleman from Texas, Mr. Doggett, for his opening statement.
Well, thank you, Mr. Chairman. I know how passionate you are about healthy lifestyles and chronic disease prevention. I appreciate the panel that you pulled together for us today. An estimated 2 million Americans die each year from chronic conditions, and there are so many steps that we can take as individuals. I'm sure we'll be hearing more about that today, to be responsible for our own healthy choices. But I also think we need to explore the multitude of obstacles that are placed in the way of many Americans in making those choices. My daughter, Dr. Lisa Doggett, is a family physician certified in lifestyle medicine. She recently came over with her lifestyle questionnaire with me and my wife, Libby. I told her she was cutting out everything that was fun, but the reality is that many of the foods we are consuming aren't really food. They're engineered products designed to trigger addictive habits. And as a result of her visit, I started making some changes, beginning with my breakfast cereal. After successfully manufacturing a smoking crisis and getting millions of Americans addicted to nicotine, big tobacco is one of those obstacles, replicating its playbook in the food industry, with tobacco companies purchasing large food brands and beginning to re-engineer and ultra-process their products until they bear little resemblance to natural foods. They load foods with additives to make them taste better. They're high in salt, sugar, and fat content. In one egregious example, they took the same flavor additives in cigarettes and added them to sugary beverages marketed to children. While companies across the food industry were shifting to ultra-processed goods, big tobacco-owned brands produced these hyper-palatable foods at a higher rate, manufacturing another addiction crisis. These companies also applied some of the same marketing tactics from the tobacco playbook, shifting the focus groups to include children rather than parents and repackaging products with colorful characters, catchphrases, and free toys. Candies shaped like diamond rings, cookies in the shape of cartoon characters, and other tactics to appeal to kids. Adults were sold on the convenience of ready-to-heat meals and long-lasting shelf-ready snacks. Today, we're paying the price, as the chairman indicated, in obesity rates and chronic disease rates that are skyrocketing, and particularly among young children. Mental health has declined as consumers cycle through shame and their diets contain insufficient nutrients. Many are feeling trapped from the addictions and the addictive nature of these products. While each of us must take personal responsibility for our own health, these obstacles impair the choice. So many factors intrude. Economic insecurity makes it difficult to afford natural foods. Financial struggles can mean a deficit in time as workers juggle long hours and caregiving duties. Natural foods often require preparation, while ultra-processed foods come in ready-to-eat forms for fast on-the-go Americans. Many Americans are also living in food deserts. I have some right on the edge of my district with few healthy food options at local stores, or perhaps in food swamps where the only options are ultra-processed foods. I appreciate some of the Medicare Advantage plans that are making access to nutritious meals, but I remain concerned that too many plans severely restrict supplemental benefits to certain consumers in geographic areas. Meanwhile, ads mislead consumers into thinking they'll receive free meal delivery, gym membership, and more. For those who are eligible, fine print caveats limit the value, and the promised benefits are often just nominal discounts. MA plans, I believe, are being dramatically overpaid, costing taxpayers billions more each year than traditional Medicare. Rather than overpaying private insurance plans, we can cut taxpayer waste and use the funds to improve traditional Medicare by covering nutritious meals and other benefits like dental, vision, and hearing. These are important steps to treat the crisis that we're in, but we should not just be in the sick care business. We must also address root causes, including the proliferation of these cheap, ultra-processed food products. I look forward to hearing from our witnesses about the challenges to maintaining a healthy lifestyle and the solutions that we can encourage to improve the health of all Americans. Thank you, Mr. Chairman.
And thank you. I will now introduce our witnesses. Senator Bill Frist is a former United States Senate Majority Leader and doctor from Tennessee. Dr. Mark Hyman is founder of the Institute for Functional Health. Dr. Ann Peters is a senior scholar with the University of Southern California. Dr. Rinaldo is Chief Clinical Innovation Officer at SCANS Health Plan. Dr. Ashley Gearhardt is the Professor of Psychology for Food and Addiction Science and Treatment at the University of Michigan. Again, thank all of you for joining us today. Your written statements will be made part of the recorded record, and each of you will have 5 minutes to deliver your remarks. I might be a little more generous with that today, but try to keep it somewhat in the ballpark. And Senator Frist, if you're ready, you can begin.
Thank you, Chairman Buchanan, Ranking Member Doggett, and distinguished members of the committee. Having spent many more than 1,000 hours on that side of the dais, I'm truly grateful for the opportunity to be with you today to share my thoughts and my experiences as a physician, as a policymaker like each of you, and as a business person looking at innovative places to invest and approach this really challenging issue of food and nutrition. I've personally written tens of thousands of prescriptions for treatment and for prevention of disease, literally with my hands, but I've never written a prescription for food. But that's really about to change. I know it's about to change. And here I'm to talk a little bit why. And it's because nutritious foods are now recognized as being fundamental to prevention of disease, to the treatment of disease, to improving health, and to lowering cost. And as the chairman mentioned in one of the articles I wrote, it's really because it's fundamental, and we're going not to just treating the symptoms of a problem, of a challenge, the disease burden in this country, but to a fundamental root cause of disease. I've got 3 points really to make. First, the opportunity. Poor diets are the leading risk factor for death and disability in the United States, causing more health harms than tobacco use, than alcohol, than opioids, than physical inactivity or air pollution. Americans of all incomes, races and ethnicities, in all political parties, in every state, in every city, are affected. But in particular, those with lower incomes, living in rural communities, and from historically marginalized groups, face the greatest burdens. And they fall further and further behind due to these out-of-pocket expenses, to lost wages, to lost jobs, to depleted communities. The nutrition problem really is not complicated. Americans eat first too much refined starch, sugar, and salt, often as a part of the foods, as the ranking member just mentioned, processed far beyond their natural forms, and 2, not enough fruits, vegetables, beans, nuts, whole grains, seafood, and yogurt, which we know, scientifically know, promote health and protect against disease. Poor nutrition, as was pointed out, is crushing our economy. The numbers, the U.S. economy loses an estimated $1.1 trillion each year in direct medical costs and productivity losses due to poor nutrition, and has the impact of increasing the federal deficit and thus the federal debt. As the chairman mentioned, poor nutrition is a national security issue. Nearly 8 in 10 young Americans do not qualify, 8 in 10 today, for military service. By far, the #1 disqualifier is overweight and obesity. Second point, food is medicine. What is it? What is that power itself? Food as medicine refers to a set of food-based nutrient interventions, active interventions, integrated into healthcare, and that's where the failure lies. It is not integrated today into healthcare to treat and manage specific disease conditions like diabetes and like high-risk pregnancy and heart failure, my specialty of the heart, chronic kidney disease, and cancer. We need to keep it clear in our mind, it's not just about prevention, it's about medical therapy itself, and I think you'll hear more about that from the other witnesses. The food as medicine programs include, what are they? They include treatment with medically tailored meals. Medically tailored meals, those are meals that are specifically tailored for very specific conditions. Again, more to come on that. It includes medically tailored groceries, produce prescriptions covered by health insurance, nutrition coaching and culinary education, medical nutrition education for doctors. Again, this isn't a social program or another way of doing assistance. This is prevention, and it is therapy. The demonstrated, proven benefits include less food insecurity, more healthy food intake, better health, including lower blood sugar levels, lower blood pressure, and body weight. They make financial sense. Compared to other common medical interventions, these food as medicine programs are either a healthcare sort of best buy, or they actually lower cost saving. For example, research from Tufts University estimates that about 6 million Americans qualify for medically tailored meals, and providing this treatment to these patients will save nearly $14 billion annually. Third, the policy implications, and I've outlined in my testimony policy implications that I hope that you'll consider specific for this committee, and also in that written statement, what other committees might consider as well. In closing, the food we eat, really as directly as anything that I've seen in my 25 years of practicing healthcare and 12 years in policy, directly and powerfully impact our health, directly and powerfully impact our economy. It hits at the root cause. They improve health, prevent disease, enhance well-being, save money for the individual, save money for the employer, save money for the community, and save money for the nation. Thank you, Mr. Chairman.
Yeah. Thank you, Dr. Hyman. You're now recognized.
Thank you, Mr. Chairman and members of the committee, for the opportunity to testify before you today. My name is Dr. Mark Hyman. I'm the chairman of the Food Fix campaign. I'm the co-founder and chief medical officer of Function Health, the fastest growing consumer health platform in America, empowering people to live 100 healthy years through data-driven healthcare. As both a doctor and a concerned citizen, I'm very grateful for your focus on food and the chronic disease epidemic facing our nation. I especially wish to thank you, Vice Chair Buchanan, for your leadership in establishing the Bipartisan Preventive Health and Wellness Caucus with Congressman Moore. It's a critical step in addressing the human and economic burden of chronic disease. And like you, I'm deeply committed to reversing America's chronic disease epidemic by addressing its root cause, our modern ultra-processed diet. Unlike healthy foods, ultra-processed foods are high in sugar, starch, refined oils. They often contain industrial ingredients such as preservatives, emulsifiers, artificial flavors, colors, and sweeteners. Also, they have a long shelf life and are fast to prepare and eat, but with devastating consequences. Nutritious food has the power to make us healthier, but processed foods drive the chronic diseases that are the leading cause of death and disability in the U.S. today. 60% of Americans have at least one chronic disease, 40% have two or more. 93.2% of Americans are metabolically unhealthy. What does that mean? It means they have high blood pressure, high blood sugar, abnormal cholesterol, are overweight, or have had a heart attack or stroke. That means 6.8% of Americans are not metabolically unhealthy. And 1 in 10 Americans has prediabetes or type 2 diabetes, including 1 in 4 teenagers. And the culprit is what we consume. About 60% of our diet is ultra-processed foods, which are new to nature foods. They're not really food by the definition of food. And among children, the share of their diet that's ultra-processed food is 67%. For every 10% of your diet that's ultra-processed food, your risk of death goes up by 14%. It's the #1 killer globally. Ultra-processed foods also impose a huge burden on our healthcare system. Since 2000, national healthcare spending has ballooned from $1.3 trillion to $4.9 trillion. But although we're spending more and more, we're getting sicker and sicker. We rank 30th in the world in key healthcare metrics, like infant mortality, and last among developed nations. We are 48th in life expectancy. I think Cuba's higher than us. We accounted for 16% of the global cases of COVID deaths, even though we're only 4% of the world's population. Why? Because COVID kills the chronically ill and obese. Fortunately, there's a solution. It's harnessing the power of eating more nutritious foods. The fact is that most diet-related chronic diseases are preventable and, as Senator Frist said, even reversible if we change our diet. And that is the Food Fix campaign's singular goal. Now, fortunately, there's mounting research that proves that food is both the cause and the cure for most of our chronic disease epidemic. Yet doctors do not learn about nutrition, nor does our healthcare system reimburse for treating patients with the most scientifically effective tool to reverse chronic disease, food. Take Janet. Hope we can show her picture here. This is Janet, who was a minister from Ohio, came to our center at Cleveland Clinic. She had obviously severe obesity, type 2 diabetes, on insulin, heart failure, hypertension, fatty liver, failing kidneys, on her way to a heart and liver transplant. Her annual copay for medication was $20,000. After 3 months, she reversed all of her diseases and was off insulin and all her medications. This is something we learned is not possible in medical school because we don't learn about how to use food as medicine. And this is Janet a year later. She lost 116 pounds and got her life back. The data clearly demonstrate that we can not only prevent type 2 diabetes, but we can reverse it. And data show with a ketogenic diet that 60% of people can have their diabetes completely reversed 100% reduce or eliminate their medication at a savings of $6,000 per patient after the cost of the program. If scaled across Medicare, this would save over $90 billion a year. Now, here are ways you can address the problem. First, I want to applaud Chairman Buchanan and the committee for including in the American Medical Innovation Investment Act a medically tailored meals demonstration in Medicare. Now, under this incredible demonstration program, qualified beneficiaries would receive medically tailored, home-delivered meals and medical and nutrition therapy. And in the future, the standard of care can be further incentivized with a Medicare add-on payment for nutrition-focused treatment. Second, we must train tomorrow's clinicians in the science of nutrition and its role in causing and curing chronic disease. In medical school, I learned nothing about nutrition. 40 years later, my daughter, a fourth-year medical student, also received zero nutrition education. We can change that by setting minimal competency requirements in nutrition in all federally funded medical schools and graduate medical education. And finally, I encourage the committee to consider a novel but proven direction. And I believe this could change so much about what's wrong with our country. We all know that changes in diet and physical activity can reduce the risk of developing type 2 diabetes by 58%. But new research clearly demonstrates that type 2 diabetes is not only preventable, but reversible. And that's why I encourage you to establish a national diabetes reversal program to address the single biggest driver of disease and costs in our healthcare system. In closing, I want to thank you all for all you're doing to solve America's chronic disease epidemic. This is a national emergency, and it demands a national, bold response. We know that food is medicine, and together we can build a healthier and more productive and safer future. Thank you.
Thank you, Dr. Peters. You're now recognized.
Thank you. Mr. Chairman, Mr. Vice Chairman, and honorable members of the subcommittee, thank you for the opportunity to testify about how we can create incentives to better prevent and treat chronic disease. I'm Dr. Ann Peters, professor of medicine, clinical medicine at the University of Southern California and senior scholar at the USC Schaeffer Institute. The views I express are my own. Chronic diseases are a growing health and economic burden. By 2030, cumulative chronic disease costs could reach $42 trillion. This staggering figure underscores the urgent need for our shift in our approach to healthcare. As a diabetes specialist, I've spent my life devoted to preventing disease and its complications. I've written papers, books, and guidelines to help others understand the need for preventive health care. Lifestyle modifications, newer medications, and wearable technologies can help reduce the risk for diabetes. But access is disparate and largely dependent on socioeconomic factors. Most primary care providers don't have the time or tools to help people achieve sustained lifestyle change. Our healthcare system understandably pays surgeons a premium for performing heart surgery or removing a leg, but doctors like me don't get paid much for preventing cardiovascular disease or an amputation. The misalignment of priorities is at the core of our chronic disease crisis. I've treated many thousands of patients, some in affluent Beverly Hills and some in underserved East Los Angeles. The disparity in outcomes is stark and heartbreaking. My Beverly Hills patients live to become really healthy 80 and 90-year-olds. I can't remember when my last patient from this community lost their vision, had an amputation, or started on dialysis. Almost none have heart attacks or strokes. But in East LA, I see patients every week in their 20s and 30s who have developed life-altering, preventable diabetes complications, blindness, kidney failure, the loss of a limb. These patients rarely live to grow old. What is especially heartbreaking is that this is preventable. Our research has shown that if we provide these patients the resources they need, we can improve their outcomes. Everyone benefits from preventive health care. The data support that prevention is worth our investment. Schaeffer research predicts that the social return on investment from treating adults with moderate obesity is more than 15% per year. Recent scientific advances suggest it may be possible to slow the aging process and delay the onset of chronic diseases. This approach could extend healthy lifespans and compress illness into a shorter period at the end of life. Interventions include new therapies for neurodegenerative diseases and addiction, medications to reduce cardiovascular risk factors, integration of wearable technologies, and blood-based cancer screening. Even moderate success in delaying aging could yield enormous benefits. One analysis found that by slowing aging by just 2.2 years could reduce the incidence of major diseases by 7 to 12% and save over $7 trillion in healthcare costs over 50 years. To realize these benefits, we need policy changes that incentivize prevention and health. Some of our recommendations include reimbursing physicians for patient outcomes, encouraging multi-year insurance contracts, ensuring innovators are paid a reasonable rate of return, and implementing value-based reimbursement models. In conclusion, the challenges posed by chronic diseases are immense, but so is the opportunity before us. With strategic investments and policy changes, we can usher in a new era of health and longevity for all Americans. We need to remove existing barriers and change our priorities, but there's no one-size-fits-all approach to achieving long-term, sustained behavior change. Systems need to be flexible and responsive to individual needs. My experience is that it can be done in nearly all clinical settings with the right resources, education, and dedication. Thank you for your attention to this critical issue.
Thank you, Dr. Rinaldo. You are now recognized.
Chairman Buchanan, Ranking Member Doggett, and distinguished members of the subcommittee, thank you very much for the opportunity to testify today. My name is Dr. Francesca Rinaldo. I'm a physician scientist with expertise in clinical research and healthcare delivery, and I'm the Chief Clinical Innovation Officer and Corporate Medical Director of SCAN Health Plan. I focus every day on improving the quality of life for vulnerable older adults. I began my career training in surgery at Stanford University. I observed that my older adult patients often experienced poorer outcomes, not only because of the high burden of chronic disease and functional impairment, but also due to insufficient support in addressing social determinants of health. Recognizing the need to address these critical factors to provide more comprehensive care for patients, I paused my surgical career. For 2 years as a postdoctoral research fellow at the Stanford Clinical Excellence Research Center, I focused on innovative ways to improve care delivery and outcomes for older adults by addressing the intersection between chronic disease and social determinants of health. I co-developed a high-value care model for late life, integrating the most effective solutions from both academia and industry. This model addresses factors such as social isolation, functional impairment, and loss of independence, while aligning the patient's health goals and values to the care that is delivered. After leading the clinical strategy for a national network of in-home caregivers, I took on my current role at SCAN, where I use my background to keep our members healthy and independent. SCAN Health Plan, one of the nation's largest nonprofit Medicare Advantage plans, serves nearly 280,000 older adults across 5 states. Almost 50 years ago, a group of older adult activists we affectionately call the 12 Angry Seniors were unable to access needed services. Frustrated, these seniors formed the mission-driven organization that became SCAN. In its infancy, SCAN was a network of services and programs such as meal delivery, home repair, medical centers, transportation, housing support, and more. To understand SCAN's origin is to understand our purpose today. In an industry dominated by large, for-profit health plans, we believe that Medicare beneficiaries and taxpayers benefit from a robust presence of nonprofit plans. Our financial incentives center entirely around the beneficiary. Payments made to SCAN are directed towards high-value benefits and fair compensation to our providers. Nonprofit plans like SCAN are accountable to our communities, resulting in a better understanding of member needs and tangible investment in these communities. The results of this approach translate to high-quality care. For 11 years in a row, SCAN has received a rating of 4 stars or higher from CMS. Thanks to the flexibilities of Medicare Advantage, SCAN is incentivized to provide preventive care, which leads to fewer expensive and unnecessary acute care services like emergency department visits. For example, we reduce or remove cost sharing on high-value services like primary care and prescription drugs that keep chronic diseases in check. SCAN also strives to design benefits that emphasize wellness. One such benefit is meals and nutrition. We recognize that access to nutritious, culturally tailored meals, along with targeted nutritional counseling, is essential for managing chronic diseases. In 2023, SCAN delivered 41,000 meals per month under several programs we offer. These include post-acute meals, which provide delivered meals following a hospital stay, chronic condition meals, which are tailored both nutritionally and culturally to support chronic condition management, and long-term services and supports meals for our dual members, who are the most vulnerable in the communities we serve. Other examples of benefits to prevent disease are detailed in my written testimony. Congress has recognized that beneficiaries with chronic diseases face non-healthcare challenges by creating special supplemental benefits for the chronically ill. However, the chronically ill are not the only patients who face social risk factors. Low-income beneficiaries face similar challenges. To meet their need as well, SCAN believes that Congress should expand SSBCI eligibility to include dual-eligible beneficiaries, Part D low-income subsidy recipients, and other low-income beneficiaries, often referred to as the near poor, who face many of the same barriers as those living below the poverty line. Fortunately, legislation to make this change has been put forward. SCAN commends Representatives Blumenauer and Belarakis for introducing the Addressing Whole Health and Medicare Advantage Act. Congress should pass this bipartisan legislation as soon as possible. Thank you for examining this important topic today. SCAN's 12 angry seniors would be proud that the work they undertook 5 decades ago is being continued by this important committee. I look forward to taking your questions.
And thank you, Dr. Gearhardt. You're now recognized.
Chairman Buchanan, Ranking Member Doggett, and distinguished members of the committee, thank you for the opportunity to participate in today's hearing. I have been on the faculty at the University of Michigan for 12 years, and I serve as a professor of psychology and the director of the Food and Addiction Science and Treatment Laboratory. I earned my doctoral degree in clinical psychology from Yale University, specializing in addictive disorders, obesity, and disordered eating. Additionally, I'm a licensed clinical psychologist with experience treating individuals with substance use disorders, obesity, and compulsive overeating. Since the 1980s, the United States has witnessed a sharp rise in diet-related diseases. Diabetes rates have doubled, and the prevalence of obesity has tripled. Type 2 diabetes in children, which was almost unheard of in the 1980s, is now projected to quadruple within 40 years. Diet-related cancers are also now increasing, particularly among younger generations. Obesity and diet-related diseases disproportionately affect rural communities and Black, Hispanic, and Native Americans, which exacerbates existing health disparities. This public health crisis affects economic viability, workforce productivity, healthcare cost, and military readiness. A significant contributor to the rise of chronic health issues in America is the changing food environment. From the 1980s to the late 2000s, tobacco companies like R.J. Reynolds and Philip Morris became the biggest producers of processed food in the world. Internal tobacco industry documents demonstrate strategies designed to develop and sell cigarettes were applied to processed foods and beverages, such as adding flavor additives developed for cigarettes into children's sugar-sweetened beverages, and intentionally targeting children and racial ethnic communities in their marketing. Consequently, the modern food supply has been significantly shaped by the tobacco industry's expertise in maximizing profits from highly appealing products. The result has been an American food environment dominated by ultra-processed foods and beverages that have been optimized to maximize palatability and consumer appeal. These products are industrial formulations with high levels of added sugar, saturated fats, and additives that enhance taste and texture while reducing sensitivity to satiety signals. Common examples include candies, sugar-sweetened beverages, frozen pizza, and salty snacks. The average American now consumes over 57% of their calories from ultra-processed products, and this is even higher in youth. Introduction of these ultra-processed products has displaced nutrient-rich, minimally processed foods, contributing to poorer physical, mental, and cognitive health. Many of these ultra-processed products share characteristics similar to recognized addictive substances. They deliver unnaturally high doses of rapidly absorbed carbohydrates and fats, effectively triggering reward mechanisms in the brain. Research shows that sugar, fat, and ultra-processed foods can activate the brain's reward system at similar magnitudes as nicotine and ethanol. These products, enhanced with additives and coupled with texture and flavor modifications, resemble addictive substances like cigarettes, making them difficult to resist despite harmful health consequences. More than 280 studies estimate that 14% of adults and 12% of children would meet the criteria for an addictive disorder based on their intake of ultra-processed foods. This prevalence is doubled in individuals with obesity. If addictive mechanisms are being triggered by ultra-processed foods, this may be an overlooked reason why it can be challenging to reduce their intake, even in the face of life-threatening health conditions like diabetes. A participant in my lab described her ultra-processed food addiction in the following way. I can't even be in the same vicinity as a donut store or any type of donuts because I will finish a dozen all by myself, and I'm a type 2 diabetic, so that could kill me. And I know that I shouldn't be eating all those. I shouldn't be eating one, let alone a whole dozen, but for some reason, I just can't stop. A multi-pronged strategy is necessary to reduce excessive intake of ultra-processed products and improve American health. First, evidence-based strategies that have been successful and could be considered on a broader level include taxes on ultra-processed food and beverages and front-of-pack nutritional and warning labels. Second, restricting misleading health claims and marketing of unhealthy products to children, especially on social media, is another important strategy to reduce the risk of diet-related disease in children. Third, policies should aim to make healthy, minimally processed foods convenient and affordable, particularly for economically disadvantaged groups who face the greatest challenges. Lastly, investment in scientific research on the health impacts of ultra-processed foods is essential, alongside preventative measures focused on youth to promote lifelong, healthier eating habits. In conclusion, the food and beverage industries have designed many ultra-processed products to be nearly irresistible, leading to rising chronic disease levels and significant public health costs. It is crucial that we address systematic factors contributing to these issues and invest in strategies that promote healthier eating habits and health for all. Thank you.
And thank you. And I appreciate all of our witnesses, but we'll proceed now to the questions and answers with our members. And let me just start out why I'm such a big believer personally. Because many years ago, probably 8, 10 years ago, I happened to walk into Whole Foods. I'm always looking for the new diet, like a lot of people, and you realize those diets, it's up and down and it's another bust, and everybody's got 10 stories. But I picked up a book by Dr. Furman, and it just said they had an equation in there. It was very simple, and it was simply the top of the equation was nutritional quality of the food. So you got to figure out what that is. Sometimes that's difficult. But underneath that equation was the calories. So the thought was, what is the most nutritional food with the fewest calories? And that changed my life because you don't have to worry about going up and down like a yo-yo in terms of your weight all the time. You can just stay on the program. Now, my grandkids give me a hard time. I've got one back there, number 10, actually checking this out. But my point is, you realize they're saying, Papa, you can't do that or you can't do this. But my whole thing in trying to bring that point to you is that's why I'm such a big fan of, food is medicine, because it clearly made a big difference for me. And Dr. Frist, I thought what we'd do is start with you. Maybe if you could expand on that a little bit more. I'm thinking about Medicare now. Here, you know that, and you've dealt with it for a lot of years, and I'm in Sarasota region, Manatee County, Tampa region, and we have a lot of seniors, and all of them count on Medicare. But at the same token, I want to figure out, we just over this year, first time ever, went over $1 trillion. How can we apply some of these principles to help educate people to maybe take a little better care of themselves? I had a guy, a doctor that I went to, and he said was another thing on a little different thing. Some things stick with me because it worked for me. And he said, you know, they come in, they're from the Midwest or the Northeast, come into our area, and they're, you know, 70, 75 years old. They're on 4 or 5 pills, 6 pills. And he says, how would you like to get off half of those? And he said, Doc, I can't get off there. He said, no, seriously, how would you like to get off half? He said, what are you talking about? He said, I want you to start walking 2 miles a day, 5 days a week. And when you can do that for 30 days, then you come see me. And I'll take you off half of the garbage you're on. But it's not that it's all garbage, but my point is there's something to be said for that as well. But what's your thoughts? We're spending over $1 trillion. You know, we've got the debt and the deficit. You brought that up. But I'm obviously very concerned about that, but I'm also concerned about, you know, the healthcare and where all this is going and how we start bending the curve on some of the costs. Because we're paying more and more, and we're getting less and less. I think everybody pretty much, especially in the last 10 years. So what's your thought, Dr.?
Thank you, Mr. Chairman, and I think that is the really overriding question. Given where we are today in 2024, what is different than when I was on that side of the dais and in 2003 we did the Medicare Modernization Act? And what is neat about it is, in just listening to the panel, we are in such a better position today in terms of the science itself, of whether it's understanding addiction based all the way from opioid disorder back to sugar today, in terms of the science itself, in terms of what works and what doesn't work. In 2003, which was the last big modernization of Medicare, we invented Medicare Advantage to manage patients better. And it's had its ups and downs, and I'm sure here people some are for it and against it and all. But the whole idea of being able for a group of the population to help manage, let them make their choices, making the healthy choice the easy choice, requires data. It requires information. We have underinvested in this country in NIH funding for prevention and specifically for food. Only 5% of the NIH budget goes to nutrition prevention, yet we are saying uniformly that it is a root cause of this burden of disease that we have to deal with today. In 2003, we had value-based care introduced. Our outcomes were readmissions to a hospital, death. That's all the endpoints that we have. Now with the science, we have a number of endpoints to apply. We have social determinants of health. We have the importance of food, of transportation, of access, of prevention itself. That's number one. Number two, we have Medicare Advantage, about half the Medicare population, and then we have the non-Medicare Advantage fee-for-service. I think the committee can continue to make it more uniform in terms of what is expected in terms of nutrition. Social determinants of health, there are 4 or 5 that are now recognized in 2024 today. The social determinants themselves that are required in hospitals, that could be expanded to the outpatient arena, not just for Medicare Advantage, but also for the non-medical determinants. And then lastly, I think conceptually, we need to follow the patient in Medicare as we look at Medicare policy, and not the plan, and not just the traditional outcomes, but follow the patient over time. And that takes data, good science up front, we've underinvested in the past, and then applying that science in an evidence-based way in real time going forward. With that, it becomes a true public health, both crisis, but a public health problem. Not just addressing the endpoints of admissions, what happens in the hospital, whether or not you die of a heart attack, but actually what you're eating and the impact it's having in the preventive aspects of moving forward.
Dr. Hyman, what's your thoughts on that with the idea we're spending over $1 trillion, we're spending more money than we've ever spent, but we're going in the wrong direction in terms of health care. When you look at 42%, pick a number, obesity of adults, 20% with children, that's wrong. That's sad. We could do a lot better. What's your thoughts on it?
Thank you, Chairman. I think that.
Can you put the speaker?
Thank you, Mr. Chairman. I think this is a very important issue because, as Senator Frisch said, we now have the science, and the science and the data are clear that we can solve this chronic disease epidemic by focusing on its root causes. I practice root cause medicine. Some people call it functional medicine, systems medicine, network medicine. It doesn't matter. The key is, what is the root cause? In America, we mop up the floor while the sink overflows. How do we turn off the faucet so we deal with the root cause of the problem, which is the food that's driving the chronic disease epidemic? And I think there's a lot of levers that government can pull. Many of them were mentioned here by the panel. I think a deep understanding of food as medicine is very important. I think most people still don't comprehend that food is not only something that can be used for prevention of disease, but for the treatment of disease, and that it often is a better treatment than medication. Medication has a role. It's important. It's not that we want to get rid of it, but we have to understand what is the actual right treatment for a patient. Just like this patient, Janet from Ohio, she lost 116 pounds and reversed all her diseases. This is not something that you could do with medication. She was already getting the best medication from the best healthcare system in the world, and yet she wasn't getting better. And I've seen this over and over in clinical practice. We've demonstrated this in our research at Cleveland Clinic. There's many data points that we have in the scientific literature that by applying the science of food as medicine, that we can transform biology. And for those of you trying to understand what does that mean, what does food as medicine mean, it's not just a metaphor. Food is literally a code that you're eating. Every molecule in the food you're eating translates into changes in your biology, in your gene expression, your immune system, your brain chemistry, your microbiome, your hormones. They're all regulated by the molecules you eat. And if they're molecules that produce health, it creates health. If they're molecules that produce disease, you get sick. And primarily the molecules that we're eating in America are not actually food. Food, by the definition in the Webster's Dictionary, is something that promotes the growth and health of an organism. By definition, most of what America's eating in ultra-processed food is not food. It actually does the opposite. It promotes disease. So I think understanding how do we make nutrition central to healthcare? How do we reimburse for it? And I say in my written testimony that we don't have evidence-based medicine, we have reimbursement-based medicine. How do we move to more evidence-based treatments? In fact, every professional association, American Heart Association, National Heart, Lung, and Blood Association, from the NIH, the American Diabetes Association, all recommend lifestyle therapy as the first-line therapy for treating high blood pressure, for diabetes, for heart disease, and yet it's not done in healthcare because it's not reimbursed. If tomorrow doctors were paid to do the right thing, not the thing which they get paid to do, this would change very quickly. So I think the medically tailored meals program, produce prescriptions, incentivizing nutrition services and payment services for physicians in healthcare is critical. I think reforming our medical education system. I think the federal government spends $17 billion for graduate medical education. None of it comes with any ties or recommendations for including nutrition services. I think some of the work we've done and you've done, Mr. Chairman, has helped change that, and the ACGME, the American College of Graduate Medical Education, is now going to provide nutrition competencies as part of their training. And I think that we have an opportunity to do some really bold things through CMMI and Medicare demonstration programs like a diabetes like a diabetes reversal program, which has never been done before.
Doc, let me ask you, both of you, someone said like 30 years ago, I hate to bring up these stories, but some things have an impact on you, your heart doctor. He said that 50% of people that have their first heart attack don't see the next day.
That's right.
I don't know if that's true or not, but that's what I was told.
That's right.
I thought to myself, how do you not have the first heart attack to begin with?
That's right.
What can we do about that? So I want to, in terms of prevention, I'm just looking at how much we're spending, and only 3% of dollars are allocated for federal dollars for prevention. That makes no sense. It's kind of like lung cancer and these other things. If you don't do the test, you get into a lot more expense. Someone says, well, I can't afford to eat that way. So in some ways you can't afford not to.
Yeah.
But you're the heart doctor. What's your thought about this whole idea of prevention and 3%?
I think from the policy-making standpoint, now, first of all, it's not just government. This is to empower individuals to make the healthy choice the easy choice is what I think policy needs to actually do. So we need to, A, support the science, get as much evidence as we possibly can. The 3% figure is exactly right. The 5% figure I gave for funding about nutrition research, so we really know what works short-term, mid-term, and long-term. We're going to actually have to increase that body of knowledge. The testing, and this committee has done superb work in passing legislation to increase the testing early on, the diagnostic testing, which is unbelievable. I think, which is fantastic, because if you're not testing early, you're not going to pick you up early. And then from the old days, or my days, and where we are really with Medicare today, we do well in terms of treating the heart attacks and the diabetes. It's really expensive. And to lower that expense, we're going to have to get from the testing, make sure that people who have a positive test actually get the treatment themselves. And that means that there are real opportunities for you in this committee to make sure that, yes, A, you get the test and you've moved in that direction. The acute care system today and chronic disease system needs to be improved systematically, but there is a gap in between the two to make sure if you get that particular test, you actually get the ultimate treatment that you need at a point in time. And that gives opportunities for these newer technologies like telemedicine that after COVID we realized are so important to bring people into the system. And that's where I think a lot of the policy opportunity is today. Yeah. So first, the evidence is, the food as medicine is crystal clear today. What we need to do is to be able to build that body of knowledge over time, have policy actually set the guide rails, and then recognize that the private sector, the nonprofit, which SCAN is a beautiful model of, and the for-profit sector to be able to accomplish the reality of what the policymakers intend, all working in hand.
Yeah.
Well,
If I could add, I would just underscore Senator Frist's point about nutrition research. The NIH spends $48.6 billion on research every year. $121 million is spent on nutrition research, a fraction of that, and yet it's the single biggest driver of all the diseases that all the institutes at the National Institute of Health are studying. And that needs to change in order to actually further study this problem. And I also think that we have an opportunity to really rethink our whole approach to treating disease, not just preventing it. I think prevention is important, but 5% of the population accounts for 50% of the costs in Medicare. And focusing on that group will create the best ROI, and I believe with CBO will create a potential scoring that allows this legislation to pass. I think it's essential we think about things a little bit differently. Prevention is important. We need to figure out how to do public health campaigns. We need public health measures that include, nutrition, education of the public, addressing the food marketing in countries. The UK just banned food marketing to kids, from during the day. Front of package labeling to help educate consumers like they do in most other countries in the world. They're far ahead of us in policy, and they're seeing the changes and benefits to their population. And yet, we're not addressing these things in a serious way. And I think this, as I said in my testimony, is a national emergency, and it needs to be treated as that. I hope the next president will declare such an emergency and put a focus on it as we did for COVID, whether we did it right or wrong. We had a focus on it, and we put resources to it, and we put efforts of the government behind it, and I think that's the kind of effort it's going to require.
thank you. Mr. Doggett from Texas.
Thank you very much,
recognized.
Dr. Gearhardt. I was struck by your testimony on the challenges consumers face in maintaining a healthy lifestyle. While we should make these healthier foods more affordable and convenient, many consumers will still select the ultra-processed. Can you elaborate on how these products trigger addictive habits?
My pleasure. Thank you for the question. Addictive substances are things that man makes by taking often a plant or a fruit and processing it and altering it so it rapidly delivers a reinforcing agent into the brain and into the body. We aren't really evolved to care whether we're getting enough nicotine or getting enough ethanol, but we come out of the womb liking sugar, needing fat, needing enough calories. And so now our food science technology has advanced so rapidly that they're able to make very cheap, irresistible foods that amplify the rewarding nature in the brain. And we just have really never evolved to be protected from that. And when we look at a food supply where this is the dominant source of calories in most groceries, that when people see the brands or smell the smells of the Cinnabon in the airport, it triggers such an intense desire in the brain that even if you see the salad or the very sad looking apple at the airport, it's hard to make that choice, even if you might know it's healthy for you. And so I totally agree that we want to make the healthy choice the easy choice. And we also need to help people not be so aggressively targeted and tempted by these ultra-processed products that are designed to maximize craveability, hit your bliss point, and make you want more and more and more.
What can we do about it legislatively?
Yeah, legislatively, there's a lot of options, and most of them come from the tobacco history. That is one of our biggest public health wins in decades. And we did that both by educating the consumer about the risks of tobacco, making that really clear through labeling and warning labels, but also curtailing industry practices that were questionable, like the targeting of children from marketing. Right now, there's actually tax write-offs for food companies to advertise their products to children. There's tax breaks for that. And so there's this big concern that we could do things like change the economic incentives towards healthier foods, restrict marketing to children, look at our school lunch programs and think about how do we make sure that the healthiest food is what children are getting from the beginning. And that's particularly important for our most economically disadvantaged Americans, where we're all feeling time poor and crunched. We really need to think about how does this fit into their life in a way that is achievable to help sustain a healthier future.
Well, thank you, and thanks to all the witnesses. I've just been summoned to the floor, so I'll try to get back and hear some of the other questions. Thank you. Thank you, Chair.
Mr. Smith, you're recognized.
Thank you, Mr. Chairman. Certainly thank you to our witnesses. I think this is an important topic that we want to take on. The chronic disease prevention and treatment, I think, is actually one of the biggest challenges we face, as has been mentioned, certainly within the government payment context, Medicare, Medicaid especially, and despite incredible success in research to help us better understand the causes of chronic disease alongside the billions of dollars invested in public health, overall rates of chronic disease have steadily increased. Alarmingly, some 129 million Americans, more than half of adults in our country, have at least one major chronic disease such as heart disease, cancer, diabetes, obesity, or hypertension. With nearly 90% of the $4.1 trillion America annually spends on healthcare going to treat chronic diseases, finding a way to reverse the trend is vital for our future, both for individuals and our country as a whole. While there are no easy solutions to the problem, it's clear more needs to be done to encourage people to actively manage their health in the form of regular care and prevention. The cornerstone of prevention is access to primary care and a strong relationship with the primary care provider. Primary care access is a serious challenge in rural districts like mine, which is why I have introduced legislation like the Critical Access Hospital Relief Act and the Rural Health Clinic Burden Reduction Act to support our frontline providers. We can also leverage successes in better coordinating care through utilization of accountable care organizations, or ACOs. In fact, earlier this year, I introduced the ACO Assignment Improvement Act, which would make participation in an ACO even more accessible by allowing physician assistants and nurse practitioners providing primary care services the ability to assign their patients to an ACO without an extra doctor's visit. There's also significant opportunity to improve on the treatment side of the equation. Lack of treatment flexibility and outdated payment policies can often simultaneously cost Medicare more money and make it more difficult for patients to manage their conditions. Uncertain future payment terms can also discourage providers from investing in innovative new technologies which can more accurately diagnose chronic conditions and catch problems at earlier stages. The absence of a long-term reimbursement strategy also threatens breakthroughs in access to care like telehealth expansions. Most seniors were not able to connect virtually with their primary care provider for routine consultations and telehealth services prior to flexibilities developed during the COVID pandemic. Despite the popularity of these services among patients and providers alike, and one of the largest access to care expansions in recent history, effectively all COVID-era telehealth flexibilities are set to expire at the end of this year. While House committees have marked up various extensions, not even a short-term extension has been enacted, and both patients and providers still lack long-term certainties for the telehealth services they have come to rely on. Dr. Peters, I know you have a lot of experience working to address health disparities for those with diabetes. And I was wondering, how has greater access to telehealth services helped people manage their diabetes, especially in rural and underserved areas?
Well, it's made a tremendous difference because in diabetes, we now have the wearable continuous glucose monitors, and those transmit the data to the cloud. So I actually don't have to have you in front of me. I can just look at your data and make decisions. And so we've been doing programs in our clinic where we just give everybody continuous monitors. And I can really improve outcomes, and that's both synchronous and asynchronous telemedicine. And we have a tracking system, we have remote monitoring, we check patients every day, and it really has helped enormously in my ability to reach those patients. Not everybody, however, in our clinic has access to the ability to do telemedicine, so we all worked all the way through the pandemic in person, but the people who can access telemedicine, it's tremendously beneficial. And I would be so sad to see it go away.
Thank you. Thank you. I appreciate that insight. Dr. Rinaldo, based on your experience with Medicare Advantage, how would you say plan design can better incentivize patients to build stronger relationships with their primary care providers? Any suggestions you have there?
Yes, absolutely. So in our benefit design, we often eliminate or reduce costs for preventive care services like primary care visits, especially those that are related to chronic condition management. So, for example, we have our chronic condition special needs plans related to cardiovascular disease, diabetes, and end-stage renal disease. And specifically, for example, for our diabetic members, we provide services and benefits that include no-cost insulin and low-cost other drugs, no-cost diabetic supplies, and no-cost diabetic self-management training. For our cardiovascular disease members, in our Heart First plan, we provide $0 cardiologist visits, as well as low-cost cardiac and pulmonary rehabilitation, and we provide no-cost primary care visits for these patients as well.
Very good. Thank you. I yield back.
Dr. Winstrom, you're recognized.
Thank you very much, and thank you all for being here. I've long said, since I've been in Congress, especially on health issues, that we have these hearings, we need to hear from those wearing the white coats, not just the ones writing the white papers. It makes a big difference, the people that are actually treating patients. And you know, we've done a lot, and especially as our Doctors Caucus here, in addressing these issues. You're preaching to the choir with us. It's others we have to convince of things. You know, I'm glad I live in a country with safety nets, but we got to make sure they're working. And, you know, in medicine, as you all know, there's the risk of bad luck. No one necessarily knows why they got the glioblastoma. But there's also the risk of bad behavior, and that we can have something to do with. You know, when we talk as a government, here, we talk about success being how many people you'll have enrolled in a program. And you're not checking whether the program's really working or not. Instead of looking at, hey, we've got more people healthy than ever before in America. Wouldn't that be great? You know, our goal, we keep talking about being the healthiest nation on the planet. And we can't do things like in SNAP. Okay, I'm glad we have programs to feed people that can't feed themselves. But what are we feeding them? And you know, they say things like, rather than focusing on calories or nutrition, they focus on calories. And when we say, well, we should restrict it, and these are the foods that people should be able to get in these programs. And the response we get up here, well, rich people get to buy those foods, so that's not fair. Well, life isn't fair, but we're trying to make life better. And so, you know, just talking about obesity, I was doing an interview about 1.5 years ago, and it's like, it's terrible. There's such a stigma against obesity. And I said, no, the stigma is against those who want to talk about it. And we're turning that around. That is changing, and it's thanks to all of you and some people here. You know, with the Army, I was teaching a class called the Performance Triad, and it was about sleep, activity, nutrition, right? And we talked about, and it was referenced here, we can keep people alive for a long time in this country, but can we keep them healthy for a long time? And even those with chronic diseases, can we make you as healthy as you possibly can so you can live the best life that you might be able to? So I'm just grateful you're all here, and I just want to share some things. I've said for a long time, I said, yeah, we reward the doctor that does a coronary bypass graft, but not the doctor and the patient that prevent it from ever happening, right? We got to look at those types of things, and that's what really success is. And what are the root causes? You talk about social determinants of health. We had a rural and underserved healthcare task force, because rural and underserved areas, they got the same problems, basically. I had a patient one time, diabetic, end-stage renal disease, neuropathy, trying to prevent him from ulcerating over and over again, and he says to me, I can't come to you anymore because they changed my bus schedule. And I said, well, I'm going to change my schedule then, so you can get in here. Those are things we have to address, at the local level and whatever. And Dr. Rinaldo, I was thinking we have one of our hospitals, when I went to their free clinic, they also have a food bank with nutritious food there. And so this is what they said, more people show up for their appointments because they know they're going to leave with food. And so we had another really nice FQHC, and a new large food bank was going in next door. I said, build a sidewalk. Well, they did, and they put a gazebo. And I said, so people do that. I said, you know what else you might do in here, though, is have local employers post jobs that they have available. But all of these things are very holistic and rounded. And I do have some good news. When we talk about school, I've always complained we didn't get much on nutrition or vitamins. And I did that study and on my own when I was in med school. But so Xavier University is starting a new DO school, and they're doing it because the DOs tend to gravitate towards primary care, and we need more primary care. And I talked to the new dean about prevention, and I said, and what about nutrition? He showed me his whiteboard. It was right behind me. And he has that right in with biochemistry. I said, well, that'll make biochemistry a lot more interesting. So I'm glad that you're doing that. So it is being recognized, and I think we have to keep beating that drum. But you're right. Food as medicine. Prescribe, we do that. That's what nutritionists do. That's what dietitians do. This is your prescription for what you need. So I don't have a question for you because you all got to figure it out. And I'm out of time, but I only have an undergraduate degree in psychology, but that's one of the root causes too. And I can stay away from ice cream. If I have one bite, there's going to be two. Anyway, I yield back. Thank you.
Mr. Thompson, you're recognized.
Thank you, Mr. Chairman. Thank you for having the hearing today, and thank you to all the witnesses who came. I was thinking about some things going on in my district while you were giving your testimony. I've got some gardening programs at schools, and it's amazing to see the kids not only take an interest in it, but learn to love nutritious food that come from those gardenings. I was over visiting one of the Sutter Health hospitals in my district last week and saw a pretty interesting food nutrition class program that they have to educate their patients, which was heartening to see. Adventist Health in my district is a big proponent of the blue zones, and they're pushing this, and it's all the things that we all know we need to be doing, but then we also know there's other problems. I have food desert areas in my district where you can't get good food if you know that you need to have it and want to get it. It becomes very, very difficult to purchase it. And as we all know, that the ultra processed foods are cheap, they're easy to get, and as you all have said, that triggers certain desires to eat more of those. And that's just not a good thing. And I wish that you could give us some idea how to fix those things, because we've been trying to deal with the food deserts forever. The advertising issues that you raised, good luck fixing that. You know how difficult it's been to deal with the private sector and advertising pharmaceuticals, driving consumers to drive crazy their doctors to prescribe the things that they see on television. So it's a tough one to deal with, and the education is good, but this is not new. You know, we learned about nutritious eating habits when I was in grade school. But there's so many distractions and so many alternatives that taste good and trigger those desires. So I'd be really interested in figuring out how we could figure out some policy that on both sides of this dais we could work on to get us to a more healthy population. Dr. Gearhardt, in your testimony, you discussed the impacts of a diet full of ultra-processed foods. You mentioned that this type of diet leads to physical diseases, heart disease, obesity, and also anxiety and depression. I mentioned earlier that Adventist Health in my district is a proponent of the Blue Zone Project, which focuses a lot on food. Food is medicine, eating healthy. And I'd be interested to know if you know about that program and your thoughts about that, and how we could maybe mimic that in other areas to get people to eat a more healthy diet.
My pleasure. I'm not familiar with that specific Blue Zone program, but I am familiar with the research on Blue Zones, and that's looking at places around the world where people are living the sorts of lives that we're talking about here, long-term health.
That's what Adventist is trying to push, is to creating those
that
opportunities and push people towards those types of eating habits.
I think that's really so essential because we are talking so much here on the individual, and it's important to equip individuals with this knowledge about healthy eating and ways they can live better lives. And then I look at, I grew up in rural Ohio, and when I go home, we don't have a grocery store anymore. We're farmers, my dad's a farmer, but the food that we're creating is actually the ingredients that go into processed foods, and the rates of obesity and diabetes are going up so dramatically. And so taking these environmentally focused initiatives where we're setting it up for the individual where they can thrive in ways that are achievable for them, I think is really key. Because we've talked a lot about food deserts, but there's also the food swamps. So if you have the one grocery store, but you have to walk past the 20 different convenience stores that are promoting the soda and the salty snack that's activating that reward system, that desire system of your brain over and over and over again to get to that more expensive, less convenient food, it's probably not going to work that well for most people. So those upper level approaches seem to be really key.
Thank you. That was a fast clock, Mr. Chairman. I yield back.
I want to recognize Dr. Murphy, but I do want to say I'm so glad we've got two very bright, capable doctors that are on our team here too. So, and Dr. Murphy's one of the two.
Somewhere else. I didn't know where you were talking about. Thank you guys for coming. You know, sitting here looking up what ultra-processed foods were, the staff in this place is going to go crazy when we get rid of the energy drinks, because that's the number one that they put on. And then I saw vegan meat. How about that? How about that, guys? That's going to toss back. But thank you, guys. I think there is full recognition on this committee that medicine or food is medicine. The real question is, how do we get, and you know, when I tell a patient, and I still see patients, to stop smoking, to do this, do that, and if you write a prescription, they're going to go to the drugstore and fill it. But the next time they go to the grocery store, may think in their mind, but are they going to do something different? And so there is a point of coercion where you have to have some of these foods. I look back, you know, when I grew up in junior high school and high school, you didn't have soft drink things in the gym or in the cafeteria. You didn't have any of that stuff. You got water or milk, or sometimes you got that, you know, purple juice or whatever that you had. But it is a change. We've also taken exercise out of our schools. The presidential exercise program, fitness program has gone away. So this combination with food, because exercise is healthy also. So I want to pare down on one of our more really at-risk communities, and those are folks on Medicaid and on SNAP. I sadly enough see a lot of end-stage renal patients, a lot of folks who have faced diabetes, a lot of folks who hypertension, et cetera, et cetera. But we don't have anything really in SNAP that says you have to eat nutritious food. And if I'm in the grocery store and I'm looking behind and I'm looking, God forbid I just try to hide my potato chips. I've done better. I promise you I've done better. But it's time that we actually did that, because those are at a higher risk population. Those are the ones who end up costing the system more. Those are the ones whose longevity is decreased. So what do we do with SNAP? How do we fix this? How do we then say, look, this is for nutritious food. It's not for soda. It's not for chips. It's not for cookies, in a way that still gives people choice. Because remember, at the end of the day, it is personal choice. You can't force them to take a medicine. You can't force them to eat a food, especially stewed broccoli. But anyway, so I'm interested, Dr. Frist and Dr. Hyman and anybody else on the committee, how do we deal with SNAP? How do we say this is for folks for nutritional assistance, but it's nutritional assistance, it's not caloric assistance?
Yeah, I'll start, and Dr. Hyman can add to intelligently. The Farm Bill is underway, and again, this is multi-jurisdictional. This is sort of changing behavior that is new. Obesity was not a problem 50 years ago.
Nope.
The diabetes to the effect we have today was not a problem. So it is fixable. And I think what you've heard beautifully, I think, as we've presented, it is the creation of industry in large part.
Sure.
An industry that, and I'm, out with business for profit, I'm out with capitalism, I'm out there all the way, but it is an industry that's out to sell, to make a profit on food. And the science today, and most of us, or all of us are scientists of some sort, the science today allows us to manipulate chemicals that are no longer really food that hit the brain.
Right.
So
if I can, I'm sorry, just our time is short. How do we fix SNAP? I know these things really trigger brain. How do we fix SNAP?
I just want to come to, let me go quicker to it. And so, and you've heard me say make the healthy choice the easy choice, but people on SNAP don't really have, but many people on SNAP don't have the choice, because if you see a sugary beverage or a fruit drink, both of which have lots of added sugar to it, versus an alternative, that's not really a choice because of the addiction of the brain itself.
Right.
So SNAP itself, what is it, 20-30% goes to sugary beverages.
Yeah.
That is the killer. That is the cause of chronic disease today. So I do feel this is personal based on my policy making, like you, and health, that we should limit, if this is taxpayer dollars, that as a choice, since we know it is an addictive choice. Now, you can look to the WIC program. I think the WIC program is ahead of the SNAP program, and I would look to the WIC program and adopt some of that at the SNAP level.
I think it's important. My time's just about expired. And somebody say this may be very paternal, telling you what to do, but this is an at-risk population. There oftentimes are food deserts, without a doubt. But if we don't start putting some personal responsibility, and if people aren't going to be able to do that, and they are, good Lord. I've seen 2-year-old kids come into the patient with their mother drinking a Mountain Dew. We have to put some responsibility, because they're going to have so many deleterious effects in the weeks and years to come. Real quick, Dr. Hyman.
Just quickly, I think we need to put the N back in SNAP. Nutrition security, not just food security, not just calories, but also nutrition that drives health and wellness. I think incentives for purchasing healthy food have been demonstrated to be effective, and disincentives for purchasing unhealthy food. That can be built in. I think that focusing on nutrition security as well as food security is essential, and I think people want it. And I think people on SNAP would benefit. And the data show clearly that those who get the incentives for good food and disincentives for unhealthy food actually create better health outcomes and better overall health for the people who are doing it. So there are models for this.
Absolutely.
There's actually a program at the Indian Health Service, I think in Native American reservations, which is like SNAP, and they get a choice between Whole Foods or just SNAP, and they all often choose Whole Foods, which they have on the reservations. We can expand that to the rest of the nation.
Great. Thank you, Mr. Chairman. I'll yield back.
Mr. Hearn, you're recognized.
Thank you, Mr. Chairman, for having this important meeting. As a person who actually lived on food stamps many years ago when I was young, and 4 siblings younger than me lived on food stamps, we have this debate about what can food stamps buy today, SNAP, let's call it what it is. And there's a debate about, as one of my colleagues said, is that, well, the rich people get this.
There was a time when that wasn't so. I remember standing in line with my mother, and she would buy some of these things that we're saying are just for everybody now, and I would have to take them back. You know, you always get called by your middle name when your mother's trying to get your attention. She said, Kevin Ray, you can't buy that, and so you got to put it back. And so there was a time when we cared about nutrition a lot in our families as we were trying to move people onto their feet. So I've got a series of questions, Dr. Hyman. I saw you this morning. I said, you know, usually I have a big diatribe, then I ask like 2 questions real hurriedly and use all my time. But, you know, we do have a nexus, and it's kind of a real tough situation. You all are giving us a problem, and Dr. Murphy said this a minute ago. We hear these problems all the time, but nothing's getting solved. It's getting worse, and that's got to be extraordinarily frustrating. I know you are, because we talked last night and again today. So I'm just going to run through some questions. So you've given us the numbers on obesity, what it is in the United States and how it's continued to grow. So my question is, are we still measuring, you know, we get hung up on things being measured differently today than they were 10, 20, 30 years ago. Are we still measuring obesity the same way today that we did 10, 20, 30 years ago?
Yes, it's defined as overweight as a body mass index of 25 or more, obese is 30 or more. And when I graduated medical school, there wasn't a single state with an obesity rate over 20%. Now there's not a single state with an obesity rate under 30, and most are well over 40. 42% is the national rate. By 2030, it's estimated that 1 in 2 Americans will not be overweight, but obese.
So you're saying that we have not changed the numbers to make the problem look worse?
No, the definition's the same. I mean, we can talk about BMI as a valuable metric or not, because body composition turns out to be more important. If you're someone like The Rock, you're a big guy, your body mass index is very high. It doesn't mean you're overweight. It means you have a lot of muscle. So the definitions are not as clear, but I think the problem we're facing is one of a metabolic dysfunction, which has to do with insulin resistance, which is driven by sugar and starch in our diet, and that is what's driving most of the chronic disease, from heart attack to strokes to cancer to diabetes.
Well, I'm not a doctor, didn't mean to interrupt you, but while I'm not a doctor like my 2 esteemed colleagues are, you know, I spent a lifetime in business and understanding human nature, and was pretty successful at it. And I'm probably pretty successful still to this day. And there's a lot of really smart people that could, if I could do things for you, I would, but I can't. So we have to incentivize people.
That's right.
And in my world of business, and we all worked in the same models, we all have businesses, but the ones who are really, really successful understand what motivates people to be better in themselves. They don't have to be the most educated, but they can be the best themselves. And it's got to be extraordinarily frustrating, because you all see the end game. If you don't, you're not going to live as long, friends, if you're obese. It's just not going to happen. Or if it is, you're living on borrowed time. And so we're trying to tell people this, but it doesn't change anything. It's only getting worse, as you all have all described. So why is that? Why do people want to live shorter lives? You know, in a day and age when things are instant gratification, we have to figure out how to incentivize people, even beyond their own knowledge or capability, because we know that's going to be good for them. And that's where we need to move into what are the solutions. We deal with taxes on this, we deal with tariffs, we deal with all the problems, but it takes a special transition into what are the solutions to this. You can regulate every single business out of the food business. I spent 35 years in McDonald's, very proud of it. My kids can't gain weight, but they were very active, very athletic, stayed busy all the time. We didn't let them sit on the couch watching video games. They were working daylight to dark, which meant we were as well. But there's a part to this. One of the fastest growing places in the world on density of restaurants is China. Every major brand that we would demonize, if you all did it openly, in the United States today are in China because China wants them there. So, but Chinese people are very active. They walk a lot. High density populations that are walking a lot. So there's a lot of opportunities here for us to incentivize this. I'm a business guy. I like to figure out solutions. I'm an engineer. I like solutions. I get the problem. You guys have written tons of books. You've written tons of documents. So we don't have an information problem of describing the problem. Everybody in the world knows the United States is obese. Now we've got to move to the resolution, the solving of this. Yeah. You have got some great examples. We've got to figure out how we're going to put a study together and have some business people get involved in fixing this situation. I've got some really great ideas I shared with you last night. I'm going to move on it, because who better than a guy that spent 35 years at McDonald's to find a solution to obesity? You know, I think it's a great place to go. I want to say thank you all, because it is a big deal. We're spending trillions of dollars. We spend trillions of dollars on the symptoms, but we're not solving the problem. So thank you, Mr. Chairman. Thanks for bringing this up. I know it's a passion of yours. And thank you all for your hard work.
Ms. Sewell?
Thank you, Mr. Chairman. I want to thank all of our witnesses here today. Lowering the disproportional rate of chronic diseases in my district in Alabama has long been one of my top priorities. As a representative of the historic Civil Rights District that includes the towns of Birmingham and Montgomery, my hometown of Selma, I am sensitive to the necessity to increase health equity and lower the rates of chronic diseases for most of America's most vulnerable population. Today's hearing presents an opportunity to discuss the need for a comprehensive approach to health policy that addresses the social determinants of health. I heard that from a lot of our witnesses today. It is no secret that on this committee, that citizens in states like mine experience some of the poorest health outcomes of any state in the country. In Alabama, 67% of the people are living with a chronic disease. That means 7 out of 10 people in my district and in my state have at least one chronic disease diagnosis. Without creating and supporting policies that would address the structural, socioeconomic, and environmental factors that lead to poor health outcomes, we will continue to experience high rates of chronic diseases. This is why I am a champion of the John Lewis Equity in Medicare and Medicaid Treatment bill alongside my colleague, Senator Cory Booker. Under the current law, CMMI is not required to consider social determinants of health, such as the patient's environment, transportation or lack thereof, education, socioeconomic status when implementing and testing new payment models. This seems to me to be absurd. This lack of consideration for social determinants of health incentivizes health providers to pick patients who will produce favorable clinical outcomes. This oversight leaves women, rural citizens, Black and brown people on the sidelines when it comes to developing a payment model, and that's just not fair, nor is it equitable. I would like to invite my colleagues who have not signed on to H.R. 3069 to ensure experts at the Federal Office of Rural Health Policy and other agencies to weigh in on new payment models in Medicare that focus on social determinants of health. Dr. Peters, can you speak to how important addressing the social determinants of health is for improving healthcare outcomes in underserved communities like the urban and rural communities that I represent in Alabama?
I appreciate what you're doing, and I can tell you that social determinants of health are something that haunt me to some degree all the time because I'm so aware of the lives of my patients and how difficult they are. And so often the best doctor for their diabetes is a social worker, because the social worker can help them deal with how to find food or how to get transportation. And then we specifically have been very successful, and we have done programs in our area like the GPP, as well as Look Ahead, which is a study of weight loss in the treatment of type 2 diabetes, because my team, my educators come from the community. They work with the community. We have focus groups. We give the community the kind of care
and support that it needs
yes, that they need. And then we have peer groups. And so I'm really sensitive to the need for communities to engage in trying to help us help them. But if you give them resources, and then of course you've got to give them access to the kinds of medications they need to help them.
And the access to the kinds of nutritional food that we want them to eat. I mean, it's sort of an odd thing to say that you have a choice when, if you don't live within walking distance or even driving distance to a supermarket that has fresh fruits. It's a false narrative to think that somehow that they're not going to get the sugary canned fruit if they, try to eat
That's how we succeeded in Look Ahead, was we gave them meal replacements. And we were as successful as at sites at Stanford and Yale and wherever else because we actually gave them food. And we gave them, at that point it wasn't such great food, but nonetheless you can do it. And I really wanted to make it something that the county would pay for, is food.
No, I hear you. Listen, I feel very fortunate in my district. We have amazing partners like the Live Health Smart program sponsored by the University of Alabama, Birmingham, that has committed to providing or addressing social determinants of health. If that means a mobile unit that goes around and provides meal replacements or the like. But the Live Health Smart program is an example of the type of work this committee should be supporting. The program is committed to removing barriers in education and good nutrition, physical activity, as well as prevention and wellness. My constituents have benefited from the mobile food market that has provided access to healthy food options in 25 of the communities that I represent. In addition to providing access to healthy food, the program also revitalizes communities and neighborhoods by building parks and walking paths to encourage physical activity. I say this to say that we have to focus on social determinants of health and really tackle them if we really are to address chronic diseases. That may mean that we have to spend some money on the front end on prevention, but then we'd make it up, I would assume, on the back end by having less folks with chronic diseases and long-term death. So I hope that our committee, Mr. Chairman, will take this hearing and really make it, broaden it to social determinants of health and how our committee can address that. Thank you, sir.
You and I can work together.
Yeah.
Mr. Moore, you recognize.
Thank you, Chairman, for holding this important hearing. Look, preventing chronic disease should be one of the most important things we do on this committee, and I appreciate the witnesses for being here today. Look, folks, we have a problem in this country. 42% of Americans have 2 or more chronic diseases. Treatment for chronic diseases such as cardiovascular disease, diabetes, cancer, and obesity cost Medicare and Medicaid $384 billion annually. Chronic diseases are a substantial burden on our health system, our economy, and they're obviously a detriment to patients. More than 40% of children are now considered overweight, and more than 20% of them are obese. Instead of a society-wide initiative to get kids outside, off screens, on a healthy diet of fruits, vegetables, macros, you name it, we have pediatric clinical guidelines recommending prescription drugs. We are the richest, most competitive, most innovative country on earth, and yet our life expectancy is going down. According to CDC, only 2 in 5 young adults are both weight eligible and adequately active enough for military service. Our healthcare spending is a leading cause of inflation and one of our biggest debt drivers, but the bottom line is our outcomes are not improving. The system isn't working. We have to do better. Dr. Peters, in your testimony, you discussed the importance of aligning payment incentives toward payment for health and prevention rather than sickness. Congress has taken several steps over the years to work towards this goal in the Medicare program through Medicare Advantage and ACOs. What additional ways can we incentivize value-based or outcome-driven care in the commercial market to prevent the development of chronic diseases?
Well, I think that's a tough issue, and obviously one that requires people have consistent access to care through their insurers, and maybe creating plans where people have insurance that lasts over longer periods of time. But I think we need to take some of these things that are best practices that you've heard about and try to use those and put them in other settings, such as the DPP program, which we know has been shown to work for prevention of diabetes, and then maybe augment it and try to help using some of the newer technologies and tools that we have that might make it easier for people to understand the impact of food and nutrition on their lifestyle. And I think there are more sort of technical answers that my economist pals at the Schaeffer Center could also give you to answer that question more fully.
Senator Frist, anything to add to this?
No, I think the commercial market, the challenge there, of course, is the fact that there is a lot of spinning from plan to plan to plan. So we do need to figure out how to get the data to be able to follow patients over time in order to be able to measure what interventions work and to measure outcomes. Value-based care is outcomes sort of divided by cost itself. Traditionally, those outcomes have been things like readmissions, coming to the emergency rooms. We need to move that back upstream and look at things like the root causes, the public health model of root causes, like food itself. We just didn't set it, Medicare was not set up that way, and we need to change that over time. And we've not looked at, truly since 2018, the BBA, we have not really looked at food and nutrition as a root cause today the way that we should do in the dual eligible population, the population of Medicaid and Medicare, those 12 million people. We've not changed anything. That is where much of the chronic disease, about $500 billion is, and it's a little bit beyond the jurisdiction of this committee, and it's the challenge the way Congress has committees organized, but that overlap of Medicare and Medicaid, dual eligibles, 12 million people, $500 billion, much of the chronic disease, we need to have integrated care there, and that's where the value-based care will have its greatest impact.
Narrow that down to me. In your mind, legislatively, what can Congress do It wasn't set up this way.
Yeah.
Medicare wasn't set up this way, and to change it requires a catalyst.
Yeah.
Because we just let it continue on in perpetuity, and it's the most noxious thing that I deal with back in Congress. What can we actually do to create some change on this?
Yeah, that's, I mean, really simple thing, having sort of, again, been on that side, I would set up a hearing very quickly. What I just said about the dual eligibles is beyond your jurisdiction, and this is health versus health care. Much of what we talk about is health care. We're talking about health, which comes into the social determinants themselves. So the first thing I would do is set up an integrated hearing between the two appropriate committees in the House to look at those 12 million people. I just told you it hadn't been changed in 5 years, and say, how do we get an integrated model of health and health care and value-based care, and have that discussion for the first time in Washington, D.C. in our government.
Thank you. Dr. Hyman, quickly, you've led the charge on food as medicine. How do we incentivize better diet through healthcare without the mandates?
Well, I think a lot of it has to do with knowledge and education. I've been shocked at how little people, even educated people, know about what to eat or what not to eat. I think that's a result of the confusing amount of information in the media and in science. Nutrition science is funded 12 times more by the food industry than by the NIH. I think one of the key strategies to work around is behavior change, and I think this is something that we do know a lot about because at the end of the day, it's about behavior change and how do you incentivize that. We discussed the social determinants of health. I learned from Paul Farmer, who treated TB and AIDS in Haiti, using not better medications or surgery, but by using the power of community health workers to help people change their behaviors. And I scaled this model to the Saddleback Church in Orange County, California with Rick Warren, where we got 15,000 members of that church to do a lifestyle change program in small groups, not run by a doctor, not run by a nutritionist or any healthcare provider or health coach, just a curriculum that was supported by the church. In little groups every week, they lost 250,000 pounds in a year and transformed their lives and got off medication, ended up, reducing hospitalizations. We scaled that to Cleveland Clinic, where we created a Functioning for Life program and showed that we have 3 times better outcomes for the same patient with the same diagnosis with the same doctor, simply by using the power of group therapy. Janet, I mentioned to you, she was in a group program, a lifestyle change program. If we reimbursed for things that work and behavior change strategies, it's really around understanding the nature of these social models of change. And I think the blue zones is an example. They're a natural environment, and I've been there. I wrote a book called Young Forever about these blue zones where they live in ways that automatically create health. They automatically eat healthy food. They automatically have to move because they live in rugged environments. They automatically have social connection and meaning and purpose in their life. These are the things that drive longevity, not genes. And so those are the things that we can replicate. You're more likely to be obese than if your friends are overweight than your family's overweight. You're 171% more likely to be obese if your friends are overweight than if your family is 40%. So this is something we actually can do and reimburse. So the reimbursement for these group social lifestyle change programs, I think, is a very important thing that we could implement.
Appreciate it. Thank you.
Thank you. Ms. Miller, you're recognized.
Thank you, Chairman Buchanan. And thank all of you all for being here today. And Senator Frist, it's nice to have you back. Thank you for taking your time to be here, to help educate us and to testify on such an important issue. It's extremely personal to me and my constituents because I'm from West Virginia. And West Virginia has the highest rate of diabetes, COPD, and kidney disease in the country. Mm-hmm. This is nothing to brag about, but it is something that constantly guides my work and the work of healthcare providers in my home state. One effort that I've been very impressed by is the Food is Medicine program at Marshall Health Network that's in my own hometown of Huntington. The Food is Medicine program screens patients for food insecurity and social needs, provides medically indicated food assistance, and encourages nutritious food utilization. And this approach to chronic disease management has been working wonders for patients in our state. There's a medically indicated food box program in the little tiny town of Lavalette, which is led by a community health worker, and it recently showed that all 61 patients participating in the program have gotten their blood pressure under control. Similar food assistance programs provided to dialysis and oncology patients with food insecurity have improved nutrition and outcomes as well. Dr. Hyman, you've dedicated your career to the notion that food plays a huge part of managing chronic disease. Can you speak a little bit more on some of the benefits of getting patients on track for healthier living?
Well, it's quite astounding. You know, I've been practicing this way for 30 years, and I would say that food is the most powerful tool in my toolkit as a doctor for a broad range of diseases. Obviously diabetes, but many other things. Mental health, we know, is directly related to diet. That ultra-processed food has been linked to depression, anxiety, behavior changes in kids and adults. We know from clinical trials, for example, in other countries where they swap out healthy food for the junk food, that depression rates are dramatically reduced. We know for autoimmune diseases, for neurodegenerative diseases, for example, dementia, which is one of the most costly diseases because of the effect on caregivers and loss of productivity, is now called type 3 diabetes because of the effect of insulin resistance and sugar on the brain. So across the spectrum of chronic disease, not just the ones we typically think of like heart disease and diabetes and hypertension, but even cancer is primarily driven by sugar and starch in our diet. The main cancers, colon cancer, breast cancer, prostate cancer, pancreatic cancer. And these cancer rates are rising. We're seeing them in younger and younger members of our population, 30, 40-year-olds.
Repeat that statement right there.
We're seeing cancer in younger and younger people in our country, which is staggering to me, in their 30s and 40s.
Yes.
And the real driver is our diet. And until we come to terms with this fact as a country, we're gonna not only threaten the health of our nation, we're challenging our economy of the $4.9 trillion. 40% of that bill is footed by the federal government in one program or another. It's 30% of our federal budget. It's completely unsustainable, and most of it's almost preventable. So if we tackle this intelligently, coherently, and looked across the policies that have to be done, as Senator first said, across different committees, across different jurisdictions, whether it's Medicare reform, whether it's food labeling, front and package labeling from the FDA, or addressing the problems of food marketing to children, or addressing the problems with SNAP, or looking at our dietary guidelines or nutrition research funding. There's so many levers to pull as we try to change this tsunami that's coming at us. And it's almost been this invisible threat, because when we graduated medical school, this wasn't a problem.
No, it wasn't.
I'm old, but not that old.
Well,
I think that
I'd like to move on a little bit as well, because chronic lifestyles in patients, we also need to listen to the clinicians, because they have a big role to play here, just with screening and education, and identifying the chronic diseases and how to manage them. Studies have overwhelmingly showed us that the screenings for diabetes, cholesterol, chronic kidney disease, and cancers can be the difference in anybody's health journey. I introduced a bill called the Chronic Kidney Disease Improvement in Research and Treatment Act to address these issues just for kidney disease, and my bill would expand the Medicare annual wellness benefit to include kidney disease screening for seniors, as many patients do not know that they have kidney disease until it's too late. The bill would also increase access to the Medicare kidney disease education benefit so that physicians, as you all are, can help teach patients more about managing their disease and any of the comorbidities that they may have and not know. And so I'm happy to have voted in favor for, and she's already gone, but the Nancy Gardner Sewell Medicare Multi-Cancer Early Detection Screening Coverage Act earlier this year, my dear friend Terry, and about her mother, which would help screening with cancer for Medicare patients to ensure that they have the best information about their health that they could. Now, Dr. Peters, you have done tons of work surrounding preventive care for chronic diseases. Can you speak to the clinical benefits of increasing education and screening so that patients are more informed about their options?
I think those are incredibly powerful tools, because if you don't know you have a risk, you're not going to go find out and see if you can do anything about it. But education alone, in many areas, particularly with diabetes, isn't enough. You need to couple that with treatment, and treatment, frankly, should start with lifestyle. And so I see all of that as part and parcel of the same process. But education is necessary so people realize that they must do something. And I think that people go into these weird states of denial, and I'm not a psychologist, but they'll see family members who are blind or on dialysis, and they won't go get tested because they're too afraid to find out they have the same disease. So I think it's you can get educated. We've done programs with the churches. We've done programs with the schools. There's all sorts of ways that you can get this out there.
I have to yield back my time. You all, thank you so much.
Did I make a comment?
Is he allowed to make a comment?
Quick.
Just quick, I think screening is really important. I think we wait too late. We're reactive, not proactive in medicine, and it's part of why I co-founded a company, Function Health, to allow people access to their own biological data without having to go through insurance or doctors. For $4.99, they get 110 biomarkers that track all these things, from kidney function to cardiovascular health to metabolic health, and diagnostics that are not done at your annual physical. And we're so behind the time. Senator Frist wrote an incredible paper in the New England Journal 20 years ago that talked about how long it takes from science to become clinical practice. And I think early screening and detection is important and it's essential, and I think this is something that should be looked at very carefully as something we can motivate our Medicare patients to do, as well as our citizens in general, to do early screening and detection.
Thank you so much. Thank you all. I yield back.
Ms. Chu, you're recognized.
Dr. Gearhardt, thank you so much for your testimony. I am a clinical psychologist myself, so it's always wonderful to see another clinical psychologist. And I was heartened to hear about your firsthand experience working with those who are struggling with life-threatening health conditions. As we talk about access to nutritious foods and their role in preventing and treating chronic illness, I'm especially concerned about how this issue is impacting our nation's seniors. Roughly 7 million older adults are struggling with food insecurity, which ultimately leads to poorer health outcomes, lower nutrition intakes, and mental health issues, including eating disorders. While eating disorders are often thought of as a young person's disease, eating disorders in older adults have a mortality rate of over 20%. If left untreated, eating disorders can lead to heart failure, diabetes, and other serious chronic illnesses. That's why I've introduced a bill with Congressmember Fitzpatrick called the Nutrition Care Act, which would finally provide medical nutrition therapy services for individuals diagnosed with an eating disorder in Medicare. Medical nutrition therapy is an evidence-based medical approach to treating chronic conditions through an individualized plan, but the service is not covered under Medicare for eating disorders treatment. Dr. Gearhardt, given the rising concerns about over-processed foods and their impact on chronic illness, how can medical nutrition therapy help to ensure that seniors on Medicare receive adequate nutrition to support long-term health and well-being?
Thank you for bringing up this really important issue. Eating disorders are often very overlooked broadly, despite them having some of the highest mortality of any mental health conditions. And overwhelmingly, when we look at eating disorders, the sorts of foods that seem to trigger this loss of control over intake and intense cravings are these ultra-processed foods, that overwhelmingly these are the sorts of foods that people binge on and crave irresistibly. And often when we can actually nourish people and help them reconnect with food and also their body by helping them realize what it feels like to feel full and to feel nourished by the sort of real minimally processed foods we're talking about today, that can make a big difference. We did a poll with the Institute for Healthy Policy and Innovation at the University of Michigan with a nationally representative sample of older adults. And looking at that addictive profile of having that addictive relationship with ultra-processed foods, we found that 1 out of every 4 women 55 and older would have met the diagnosis of an addiction if that substance was an ultra-processed food. This was associated with worse physical and mental health and social isolation. So I think the more we can get our older adults access to healthy, nutritious food in a convenient, affordable way will really benefit us across multiple domains. And we've referenced here today dementia, Alzheimer's. I don't think we've fully seen the consequences of our diet on our cognitive well-being, because it's only my generation that's lived their whole life in a predominantly ultra-processed food environment. And so I think this is going to continue to grow as we age into older and older cohorts, unless we do something now to address our food environment.
Thank you for that. Dr. Gearhardt, I also want to highlight the rise of another chronic illness, addiction and substance use disorder. This crisis is worsening like other chronic illnesses, and it's a long-term condition that requires ongoing management and takes an extreme toll on physical and mental health. As we discuss strategies to combat chronic disease development, it's critical that we help leverage social support systems such as friends, families, and peer groups to encourage and maintain healthier behaviors. And that's why I've worked with my colleague on this committee, Congressmember Adrian Smith, to introduce the Peers in Medicare Act. A peer support specialist is a person with lived experience who's been trained to support those who struggle with mental health, psychological trauma, or substance abuse. And they supplement mental health professionals as part of the care team struggling with substance abuse or mental health disorders. Our bill would require Medicare to cover peer support services at rural health clinics, federally qualified health centers, community mental health centers, and certified community behavioral health clinics. Dr. Gearhardt, can you say something about the utilization of these kinds of specialists, peers who can help individuals better manage their mental and physical health conditions?
Absolutely. I've had the opportunity to treat individuals with substance use disorders, particularly at the VA hospital in Ann Arbor. And I can't tell you how essential peer-led support groups that have really flourished in the context of addictive treatment, like 12-step programs, can play such an essential role. We see that behavior change is really more effective when it's supported by other people and you feel like you're part of a group and a social network who supports you. These sorts of mental health conditions aren't just short-term, they're often lifelong changes. And we don't have enough mental health care providers in the United States, particularly in rural areas, to provide the sort of chronic care that is needed to help people sustain these behavioral changes. Peer supports can help people connect to others who understand what they're going through, reduce stigma, and promote lifelong change in a way that's affordable and accessible, and especially areas that are underserved by mental health professionals.
Thank you. I yield back.
Mrs. Steele, you're recognized.
Thank you, Mr. Chairman, and this is really important issue, and thank you all the witnesses coming out today. You know what, usually I don't eat junk food like this, and I stop eating middle of this because we're talking about nutritious food, so thank you. And then, you know, Dr. Frist, I was invited to your office when you were senator, and Secretary Chow and a few of us had dinner, and we discussed about this too, so thank you so much for coming out today. Currently, 129 million people in the U.S. have at least one major chronic disease, and increasing proportion are dealing with multiple chronic diseases. This creates a personal impact and a substantial effect on our entire healthcare system. We all must look at ways of addressing chronic disease, and I believe part of the problem is lack of access. To prevent chronic disease, I agree this is important, that we must work to improve convenient access to high quality and nutritious food that I always eat at home. Only come to committee meetings like this that I ended up eating some of junk food. And to manage chronic disease, I believe Congress has the ability to put patients and doctors back in charge of healthcare. Last year, our committee passed the Telehealth Expansion Act, which would ensure access to healthy health services for those with high deductible health plans and health savings account. This will improve access to affordable care and increase patients' choice. Congress must immediately pass this bill before the policy expires by end of this year. I also thank the committee for including the SPEAK Act in our most recent telehealth markup, which will address language barriers in managing chronic diseases. Another way we can manage chronic diseases is through innovative plans, including special needs plans. Today, we have a key witness from my district who has designed a unique plan for seniors who have severe and disabling chronic condition. And Dr. Rinaldo, can you walk me through how SCAN developed the programs for these specific groups of seniors? What kind of requirements from CMS do special needs plans need to comply with in order to target specific diseases?
Thank you, Representative Steele. SCAN is proud to offer multiple special needs plans for members with chronic conditions. As I mentioned previously, Three plans that we offer are Balance, Heart First, and Village Health. Balance is our special needs plan for our diabetic members, where they receive no-cost insulin and low-cost drugs, no-cost diabetic supplies, and no-cost diabetic self-management training. We also have Heart First, which offers $0 cardiology visits as well as low-cost cardiac and pulmonary rehabilitation. And for our members with end-stage renal disease, we offer no-cost nephrology visits, as well as a nurse that works with the patient, their family members, and their providers to basically coordinate their care and ensure they're receiving the highest value from those services. For all of our chronic condition plans, CMS requires that we create a model of care that's specifically tailored to that chronic condition, which the agency then approves. We also train all of our in-network providers on this model of care to ensure they're delivering the highest quality care that is in line with the model. And finally, CMS also requires all special needs plans to conduct health risk assessments, which we use as a powerful tool to uncover the social determinants of health that are driving outcomes for our members. So in addition to having chronic diseases, they may also have transportation or food insecurity, and we can address those things by adding wraparound services like free rides and home-delivered meals to assist in their clinical trajectory.
Thank you. Just yesterday, my bill to expand telehealth access for people with limited English proficiency passed on the House floor. And in your testimony, you mentioned that SCAN's benefit design gives patients 24/7 access to telehealth services. Can you speak further about how Medicare Advantage special needs plan benefits allow SCAN to offer wraparound benefits of patients to improve their overall health? And could you share how your supplemental benefits address cultural need of your members, especially for those non-speaking English beneficiaries?
Thank you for the question. SCAN really shares your commitment to ensuring that people with limited access and especially limited English proficiency have access to services and care whenever they need it. That's why we, along with our partners, have developed benefits and services that include 24/7 care through a telehealth benefit. And we continue to improve and add to these capabilities for our members with limited English proficiency so that they may obtain care. This includes partnering with our telehealth providers, which have clinicians that represent the communities that they serve, including primarily English and Spanish speakers. They also have an interpretation service that they can use to offer over 300 languages to members who call in who don't speak those languages. And then on the health plan side, we have member service advocates who offer assistance to members in languages like Korean, Mandarin, Cantonese, and Vietnamese, and we're continuing to ramp up recruiting for this additional staff going into our open enrollment period.
Thank you. Actually, my time is up, so thank you so much for your answer. And then, you know what, if you want to put more information into it, then you can just send to us. Thank you very much, Mr. Chairman. I yield back.
Mr. Davis, you're recognized.
Thank you, Mr. Chairman, and let me thank all of you for your testimony and the insightful information that you have provided. As I listened, I was thinking about the district that I represent, which is a very diverse district. In our city, we name areas based on where people live and how they got there. So I represent Greektown, I represent Chinatown, I represent Little Italy, I represent Bronzeville, I represent city and suburbs, I represent upscale and low income. And it seemed to me that there are huge gaps in health status in my district, as much as 25, 30 points in some lineups. And it seemed to me that the health status that stand out the most in terms of differentials is between districts or areas that are low income and areas that are not as low income. And of course, many of the groups have a tendency to have diets based upon hereditary factors and of course also based on income. Dr. Gearhardt, could you share some thoughts relative to how do we, I've been around health conversations now for about 40 years, and we have essentially the same ones that we had when I started. Could you share some thoughts? How do we really deal effectively with this?
My pleasure. And I think your instincts are accurate. What we see in the data, that health and how it shows up, it really has a lot to do with your zip code and how much money you have and how much time you have to spend on food. And I think, I've been really struck by our panel and how much we're kind of agreeing a lot about there's real nourishing food, and then there's hyper-engineered, ultra-processed foods that are making us ill. And I think that hasn't been reflected in our policies and our communication to the American public and FDA labeling and USDA guidelines. And kind of a little bit of an elephant in the room is that there is a multi-billion-dollar processed food and beverage industry that is really who is benefiting and profiting off of the current status quo. We know very little about how these ultra-processed foods and beverages are being designed in a way that make it hard for us to eat for our health. The industry will say we're trying to maximize craveability, induce a sense of moorishness, so people want to eat more and more and more. But all of that information is kind of locked behind closed doors. And so I think if there was an agreement in government policy with places like the FDA and the USDA, taxation, that really focused on, we know what real nourishing foods are, fruits and vegetables, beans, legumes, and we know the sorts of foods that are making us ill, and we made that clear, and in a system that promoted access and affordability for all people, it would really make a difference. There's a lot of targeted racial and ethnic marketing. We know that children who are Black and Hispanic and who are economically disadvantaged are exposed to more ultra-processed food and beverage ads than their more well-resourced non-Hispanic white counterparts. We're not all living in the same food environment. And so we have to do things to kind of even the playing field so everybody has the same access to nourishing food and aren't being targeted in ways that make it very challenging to resist these products that have been designed to tempt you.
Well, let me just end by, I guess, health education, health awareness, health promotion probably is as much help to these individuals understanding that ultimately it's them, to a degree, that's going to have to take much of the responsibility for their being and their health. So I thank you, Mr. Chairman.
Thank you.
And yield back.
Mr. Fitzpatrick, you're recognized.
Thank you, Chairman Buchanan, for holding this very important hearing on investing in a healthier America by evaluating chronic disease prevention and treatment. Our nation invests less than 3% of our overall health expenditures on prevention services. All the while, there are 1.7 million people that die from chronic diseases each and every year, many of which are preventable. Moreover, about 42% of Americans have 2 or more chronic diseases, and as members of Congress, we should be prioritizing and investing in prevention and living healthier lives, hence the purpose of today's hearing. This is also one of the reasons why I co-led the introduction of the Personal Health Investment Today Act, also known as the FIT Act, alongside of our colleagues, Representative Kelly, Representative Panetta, Representative Hood, Representative Sewell, and Representative Boyle. This bipartisan, bicameral legislation encourages physical activity and it incentivizes healthier living by allowing Americans to use a portion of the money saved in their pre-tax health savings accounts, HSAs, and flexible spending accounts, FSAs, toward qualified sports and fitness activities. Mr. Chairman, I'd like to submit for the record a letter sent to our committee as well as an attachment both from the Health and Fitness Association on the benefits of physical activity for preventative health and chronic disease reduction. My first question is for Dr. Hyman. Doctor, good to see you again. To quote your testimony, you state, quote, "We do not practice evidence-based medicine in America. Instead, we practice reimbursement-based medicine." Dr. Hyman, in your experience, what do you think Congress should do specifically to incentivize health outcomes associated with healthier living rather than reimbursement-based medicine?
Well, thank you, Congressman Fitzpatrick. Good to see you again as well. I think this is a critical question, and it's multi-dimensional, and I think we've covered a lot of these potential solutions. I think covering food as medicine within Medicare as a first step in nutrition services is critical. I think incentivizing providers to do the right thing by paying for nutrition services is critical. Dealing with the behavior change aspect by reimbursing, for example, group programs like the diabetes prevention program works effectively, even if it's delivered by a layperson. It's as effective as if it's delivered by a physician. And we saw this with the Saddleback Church. You know, people heal together. Community is medicine, referring to this peer support model. It works, and I think it's a very low-cost model. The patient I mentioned, Janet, she was headed for a heart transplant, which cost $1.6 million on average per patient. We spent a few $100s to put her in a lifestyle change program with a group that was effective in reversing her heart failure, reversing her diabetes. These are the kinds of things that need to be paid for. We had to kind of stick it together with Scotch tape at Cleveland Clinic by using shared medical appointment codes, required physicians to be involved, required higher-level providers to be involved. That's not necessary. These programs can be delivered in community settings like churches and can be reimbursed by the federal government through various programs. So I think by changing our incentive structures, by changing what we pay for, we can actually start to use the science to deliver on results that improve healthcare outcomes and reduce healthcare costs.
Thank you, Dr. Hyman. Mr. Chairman, I also want to highlight the importance of prevention services, specifically for cancer. Currently, there are more than 1.7 million people who receive a cancer diagnosis every single year. Our committee has advanced legislation to increase Medicare access to multi-cancer early detection screenings. Many of us are on the Cancer Caucus, which I co-chair. We've also introduced numerous pieces of legislation. Dr. Peters and Senator Frist, in your experiences, what other investments, aside from early screenings, should be made to prevent further cancer diagnoses and to get our arms around this terrible killer in America?
Mm-hmm. I think we're talking about so many things that will help. So reduction in rates of obesity will help, increase in activity, diets that aren't so unhealthy for you. And I do think we need to do more earlier cancer screening that doesn't involve tests that people don't want to go do. So the blood-based tests, if we can validate that they're helpful, that then people follow up on, I think are great ideas. But I think this fundamentally comes back to everything we're all talking about. The other thing I would add is that I don't get paid for treating prediabetes or obesity. And I need to get paid for those things, and I need to be able to use tools to help my patients take away their prediabetes and go backward to have normal glucose tolerance. So there's a lot that makes it harder for us to work in the system to do the right thing, even for our patients.
I think focusing on cancer, we talked about chronic kidney disease a little bit earlier, and I think a focus on cancer does build out the model. I think what you've heard today from all of us is, and government has historically not been good at this just because we haven't had the data in the past, but it really is to take a more holistic view in terms of where a disease starting with prevention, starting with the root causes. And the root causes that we can control are lifestyle, because so much is determined by genetics, not so much by our healthcare system in terms of treatment, but really does come back to our lifestyle, what we eat, how we behave, do we smoke, how much drinking, opioids. And the thing we've concentrated on today is food, because it's low-hanging fruit. It's the sort of thing we can do. You mentioned, and I really applaud it, in terms of what this committee has done in terms of the prevention early diagnostic test. We're going to the root causes here, the diagnostic test. I think what I would encourage the committee to do next is to look at, once you get the test done, you lower access to those tests, and the communities that we've heard about, like rural communities, are a real challenge. But once you get the test, how do we act on that? In terms of the companies that I work with in the field, there's a huge gap between if you have a positive result or a negative result, what happens? How do you get to that facility, to that access hospital, critical access hospital, to the local hospital, to the hospital 2 or 3 hours away? And that's where an opportunity, that gap, I think exists for things like, we've talked about it, telemedicine, patient navigation. You have to reimburse for that. You can't just talk about it. If you reimburse for that, I think it's a great opportunity that this committee and other committees can work on. Will have a huge impact in connecting the overall holistic view of starting with a person and ending with a disease and an outcome. We've stayed over with the outcome and the reimbursement and the value-based care. Now we need to build value-based care, not just out of the healthcare system, but all the way back to what health and well-being really is.
Thank you all for your time. I yield back, Mr. Chairman.
Mr. Horser?
Thank you, Chairman Buchanan, and to the Vice Chairman, Mr. Davis, and to the Ranking Member for holding this hearing today and welcoming me back to the Subcommittee on Health. I am eager to get to work on the issues that matter most to the people of Nevada, such as expanding healthcare affordability and accessibility, promoting health and tax justice, and creating opportunities that enable every family to thrive. Specifically, my goal as a member of the subcommittee is to advance policy that promotes equity in our healthcare settings. This includes working together to pass my bills, the Mental Health Transparency Act, which would bring more transparency to the behavioral health care space, the School Professionals Act to fix a long-standing loophole that has prevented contracted educational support staff from accessing affordable health care, and the soon-to-be introduced Dependent Income Exclusion Act, legislation that aims to make health insurance more affordable for families with children who have part-time jobs or are enrolled in job training programs. Now, on the issue of social determinants of health, earlier this year, the Nevada Division of Public and Behavioral Health released the first ever statewide health improvement plan, addressing longstanding challenges and inadequacies that have affected the Silver State, while offering several policy recommendations to improve the health of all Nevadans. The Silver State Health Improvement Plan focuses on 4 key priorities: addressing social determinants of health, improving access to health care, expanding mental health and substance use disorder services, and transforming the public health system. Now, Nevada is not alone with these priorities, and it's crucial that the state does not face these challenges in isolation. As federal lawmakers, we must continue to advocate for innovative and forward-looking policies that support our advocates and those who need this support the most on the ground. Dr. Gearhardt, the Silver State Health Improvement Plan emphasizes the importance of reducing food insecurity to address social determinants of health. Could you elaborate further on the importance of enhancing food security to the social determinants of health and suggest ways that lawmakers can address structural inequities, especially those affecting underserved communities?
Yes, food insecurity is a huge and growing issue in America, and particularly we're seeing in communities, Black communities, Hispanic communities, Native American and rural communities. It's a bigger issue. A lot of us have spoken here today that there's been a focus on food insecurity where it's just about getting access to calories, but we've all kind of been emphasizing that it'll be important for these sort of programs to also think about that people can get access to nourishing foods, really nutrient-rich foods. In my own lab, we've seen that there's multiple factors about food insecurity that sets people up to have unhealthy relationships with their body and with food in general. Part of that is that it's highly stressful to not have enough money to get the food you need to nourish yourself and your children. And that stress leads to inflammation and exacerbates many of these chronic health conditions that we've been talking about today. We also see that for many of these families, there's this kind of intermittent pattern where you'll get access to some funds at certain parts of the month, but then you run out. And so many family members will actually starve themselves, skip meals to be able to feed their children or to feed other members of their family. And then when the resources become available again, it can trigger this kind of binge pattern. That's really our biology that's been set up to help us protect against famine being used against us in a modern food environment. So having consistent, reliable access to affordable, nutritious foods will support not just the physical well-being, but also the mental health. And we see in our lab that experiencing food insecurity as a child, even if as you become an adult, you now are food secure, that experience in those critical times of your life as a child when you didn't know if you'd have enough nourishing food to eat sets you up not just in the context of diet-related chronic health disease, but also substance use disorders increases risk for that. So we really need to focus on the nutritional security of our children across the entire United States.
Thank you so much for your answer. I look forward to working with members of the committee and the staff and all of those advocates out there who support public health. Thank you. With that, Mr. Chairman, I yield back.
Thank you. Mr. Swiker, you're recognized.
Thank you, Mr. Chairman. And Senator, you actually had a real influence on me years ago to spend more time on these subjects. And actually, I've listened to a podcast of the person sitting next to you. All right. And look, for a number of our friends here, thank you for tolerating me. As you know, this is one of my fixations. I also have been listening to a number of you. I don't think any of you are pushing the envelope hard enough, far enough. So let's actually walk through, and then there will be actually a question or two here. I'm the senior Republican over the Joint Economic Committee. We actually took a leap and did something we were prepared to get the crap kicked out of us. We did the math on obesity in America. We calculate that over the next 10 years, obesity in America may add an additional $9.1 trillion additional healthcare costs. And I was prepared for the incoming. You know what happened? A bunch of the people on the left and the right came to me and said, I can't believe you were willing to say it, but it's true. You have a country where we are about to have the 5th year in a row where prime-age males are dying younger. We look at the drug statistic. You know what's just about the drug statistic? Obesity. Family formation. We actually, it's Milken Institute, we haven't been able to reproduce the numbers, says 47% of all U.S. healthcare is tied to obesity. And in many ways, we also have data that in 4 years, more than half of America will actually be up against that number. And that's a little different than, what was it? Census of those produced a number today, but it was a self-reporting poll. So it's crap from a statistician standpoint. So I come to you and say, what do you do? Are you willing to take on the way we finance agriculture, the way we do nutrition support? I would argue, is it moral to give an EBT card to go buy onion rings? Look, I represent Scottsdale. I represent a very well-educated district, but I also have a tribal community that has very high per capita income, and yet it's the second highest diabetes in, I think, the world. And now, some of that's genetic. We've learned all sorts of things about the autoimmune issues within there. Diabetes now is 33% of all U.S. healthcare spending, 31% within Medicare. So I'm going to come to you and say, okay, we've been tracking the Vertex experiments on type 1, and it looks like the data is good. We've been actually trying to look at radical ideas of a fentanyl vaccine, because over the last 6 years, we've lost 380,000 of our brothers and sisters to fentanyl. We are on the cusp of amazing changes. The fact of the matter is we already have active lobbying all up and down this campus to slow down access to glutides, the semi-glutides. But the fact of the matter is the prices are starting to crash. Look at the price difference in the last 7 months, from January till recently. Doctor, is it Hyman? Okay, you've been willing to do podcasts and long formats and walk people through. We're dying. In 14, 15 years, the United States has more deaths than births. How do I help our brothers and sisters understand that maybe the thing is wearable, maybe the new technology where I can put something on my wrist and it counts my calories. It's not a Dexcom, it actually counts my calories, so it's not blood glucose. How do I socialize the technology? Because we have a data set from our joint economists, and for our ranking member, he may find this fascinating. Number one input in income inequality was not education, it's health. How would you evangelize a healthier America and the fact that it's the single biggest thing you could do for U.S. debt? Mike.
You said something very important, is we're not going far enough, and I'm honestly held back a little bit, to tell you the truth. I think we need sweeping changes across policies. I wrote a book called Food Fix, which lays this all out from field to fork. It's how we subsidize agriculture and the commodity crops that are driving the chronic diseases. It's what we pay for nutrition in terms of healthcare services. It's nutrition education. It's our dietary guidelines. It's our SNAP program that needs to be reformed. It's food marketing, particularly to children. It's front of package labeling with FDA. It's nutrition research that needs to be done by the NIH. It's so many different aspects across government. The GAO produced a report at Dr. Mazafarian, who's in the audience, in my request, through Tim Ryan and Rosa Delario a number of years ago, that looked at all government policies related to nutrition and all the agencies involved. There were over 200 policies, 21 agencies. They found that most of these were working across purposes and actually causing more harm than good and creating more problems than solving problems. For example, we subsidize commodity crops that are turned into ultra-processed food, then we pay for $100 billion with the SNAP program, and then we pay for the back end on Medicare and Medicaid for those patients who are chronically ill. So the taxpayers are paying 3 or 4 times for the same problem, and we need to change that. So there's, I think, a set of sweeping policies that need to be done across the government that can really make a huge difference. And we may not be able to get them all done at once, but we have to work towards that. I think, slavery was at the center of our economy 150 years ago, and we figured out, not obviously through Civil War, I don't want to figure it out, but we figured out really how to end that and change our economy to something that actually created a more equitable society.
Mr. Chairman, I thank you for your patience. I have an entire binder of articles and disruptions, and with your permission, I'd like to submit those for the record. And I do hope, actually, we can have some additional conversations, because I'm optimistic we're in the time of technology changes.
Yes.
Where the thing I can have on my wrist is actually almost my primary care, helping me.
I do think that the AI-driven healthcare will create AI co-pilot for health, and it will create AI super docs that will transform healthcare. It's nothing we really talked about today, but I think it's part of what's happening outside of the traditional healthcare model, and I'm involved in that, and that's part of what our company, Functional Health, is all about.
Mr. Chairman, thank you for allowing my rambling.
Thanks. Mr. Smucker.
Thank you, Mr. Chairman. I normally don't serve on this subcommittee, but I've been sitting here. Very important for me to be here because I think this is critical, important topic for several reasons. One, I had my own experience with learning more about nutrition, exercise, and saw how much impact that had on my own life in just the past few years. Secondly, I think a lot about what I think is one of our major threats, and that is our debt and our growing fiscal, our fiscal policy. And if you look at the drivers of our increasing costs, it has a lot to do with healthcare. And so if we can solve this problem, it will have major consequences, not only on individuals' lives, as it did for me, but also on the health of the country going forward. I do disagree with a few things that were said here that I just want to mention, then I have a question maybe for Senator Frist and Dr. Hyman. I think there is a lot of new information here that hasn't existed a few decades ago. So I think there are a lot of people who don't understand the benefits of good food and good nutrition. And I think, so education, I think, is really, really important. Maybe I'm just late to the game, I don't know. But, I talk to people in my district, and they have no idea how what they're eating is affecting them cognitively, physically, whatever it may be. And so I think this really is going to require a lot of education, and I think that perhaps is the best investment here. I do want to also say, I live in Pennsylvania, Lancaster and York counties, very strong agricultural community, a lot of nutrient-dense foods. In fact, people move to my community from other states sometimes. I've talked to them who come here just for the nutrient-dense food that we have there. We also have a great industry that has come from that, and we call ourselves the snack capital of the world. So, we make, we have Hershey, we have Mars, we have Snyder's, we have Hanover. We make a lot of foods that potentially you would categorize as ultra-processed food. And these are great business people. And so, Ms. Gearhardt, I think it was, I probably disagree a little with your characterization here, but I agree with a lot of the points that you make. These are individuals who, if you talk to them, they're very concerned about the health as well. They want to create healthy products. They're responding to the consumer. So, for instance, I'll give you a real-life example of this. We had implemented additional regulations some time ago that required for the reduced salt in chips. And when they did that, they found that people weren't buying their product anymore, and individuals who, so they're trying to respond to the consumer as well. And some of the owners of these companies are looking for ways to help address the problem that we're faced with. And so I guess, Americans still like their free choice. And Senator Frist, you talked about, I strongly believe in free enterprise and capitalism and less government intervention, but that's sort of at odds with this idea that we have this opportunity where people can live much more healthily, may need to be prodded to that. What's the balance? Like, how do you address that? I go back to the I think education is really important, but Senator, what would you think is the right balance here? How do we move what is really an entire system that sort of feeds on itself, if you will? How do we move that to a much healthier lifestyle over time?
That, I think it's a great question, and it is sort of the undergirding question that we have to address. Number one, the biggest and most important thing for us to remember is that health care is not health. And the default position of is the committee structure of government, the way we've set it up, is that health care is responsible for solving the health problems. And now with the understanding that the committee has talked about the importance of social determinants of health. Let's put genetics aside, but we talked about socioeconomic status. That might be 15% of the health driver that we have today when it comes to obesity and chronic disease. We have the environment. I do a lot with the Nature Conservancy, so agriculture, you're exactly right. Regenerative agriculture we haven't talked about today, but a potential huge impact today. But the socioeconomic aspects are important. Genetics, we talked about 20%. Well, with technology, maybe soon, and some with CRISPR we can think about. But right now, with the size of the problem, the healthcare system, me as a heart transplant surgeon, the doctor, the primary care physicians, all very important, but primarily not doing the transplant, but on the education component, the trusted liaison between the patient themselves. But the 40% of the impact in terms of obesity and health and chronic disease does come down to the individual and the individual lifestyle and the individual behavior and the addiction that is part of, unfortunately, it was the industry itself that created not so much the addiction, but saw that the addiction worked, and if sugar is addictive, you're going to sell more potato chips, and you're going to play into that. And that's the important policy of our pursuit of happiness and our life that we're really all about. So the balancing act is there. And so how do we do that? And I think the best model that we have today, at least in the last 100 years, is smoking. Huge issue, caused the cancer, caused the heart disease, caused the chronic disease, and everybody in the early 1960s says it is insurmountable. We cannot do it. And how did we do it? The model was talked about earlier, and we all just need to go back and study the model. And it addressed the model, and today heart disease is not the issue that it was before. The public health issue and the burden of disease and the cost of disease has been cut down to about 1/10 of what it was because of the way government working hand in hand with the private sector And yes, it did involve some restrictions on advertising and freedom of speech and all the arguments it put out. But ultimately, it comes back to health is more than health care, and it is responsibility of each of us as government officials, but also individuals making choices and educated choices going forward. Let me just close, because I'm too very optimistic where we are today, because I think we do have artificial intelligence. We understand behavior. The scientists and the public policy people and the physicians have the tools they didn't have 5 years ago or 10 years ago, and now we have them.
Mr. Chairman, I know I'm out of time. I waited a long time. If we could have Dr. Hyman answer that question, I'd love to get his response as well. Thank you.
Yeah, go.
I think we have to face the fact that, we have to address the real cost to society of our food system. The Rockefeller Foundation determined that for every dollar we spend on food, that's about $1 trillion a year in America, we spend $3 on collateral damage. In terms of public health costs from diet-related disease, antibiotic resistance that's making us more susceptible to infectious disease, the environmental cost, soil degradation, the loss of our water resources, the pollution of our waterways, the effective collateral damage from the farm and food workers who are not properly cared for in the labor market, and that's a legacy of the Roosevelt era labor laws that excluded them from protections, and they are paid for by the government programs like Medicare and Medicaid and free care in hospitals. There's food insecurity, economic insecurity. All these are driving the costs that are externalized. And so while capitalism is important, but we're not paying the true cost of the food. The price we pay at the checkout counter for what food we're buying or for those snacks is not the actual cost to society. And we have to account for those in some way and actually create incentives for businesses to do the right thing and disincentives to do the wrong thing. And I think you're right. They do want to do the right thing. And I think what I've heard from talking to the CEO of Nestle and Vice Chairman of Pepsi and many other large corporations, they're looking at how to change. But what they hear about is this. They hear, well, if I change my product, the other companies are not going to change their product. And one of the CEOs of the company said if the government could convene all the major food companies, and there's not that many, there's like a dozen or less food companies that control the entire food supply, and bring them together to collaborate to kind of solve this problem, I think it could make a big difference. And I think they have to be kind of working together. They can't come together because of antitrust laws, but we could do that as a government to bring them together.
Let me just close on the idea of, I'm hopeful personally that more people, they care about their children. I think with the internet and access to information that we didn't have maybe 10, 15 years ago, to me, I want to say, hopefully education will make a huge difference and people will want it. They want the best for their children. And so I'm hopeful on that. So but what we can do collectively, because when you have 20% of your children that are in a situation that's going to lead to issues later in life and everything else, no parent wants that. So we've got to try to find a way to educate and do what we can to support that behavior. But in closing, I would like to thank the witnesses for appearing before us today. Please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. With that, the meeting stands adjourned.